Live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Amogs Emergency Obstetrics Committee with Uttarakhand OBGYN Societies. And today's episode is 52nd. So it's my privilege to introduce the embassy of today's webinar, Dr. Radhika Ratori ma'am. Ma'am,
Namaste.
private
Good evening.
practitioner at GR Hospital.
That's okay, Saiti. Let's move ahead, please.
I welcome you, ma'am, and I hand over the
Thank you.
session to you.
Namaste and very good evening to all my respected faculty members, all the delegates who have joined us. We are honored to have all of you for our webinar, which is with the Uttarakhand Societies, and all thank you to Sneha Bhoyar ma'am to give us this opportunity today to conduct this webinar. I would like to introduce two beautiful ladies from Dehradun who are the conveners for this session. A very dear senior, Dr. Aarti Luthra ma'am. I owe her everything. My wings are there because she is there. Aarti ma'am is a great surgeon, an excellent laparoscopic surgeon, and an excellent person, and she has innumerable accolades to her name. I welcome you, Aarti ma'am.
Thank you.
Another very
Thank you,
dear senior,
Radhika.
Dr. Meenu Vaish ma'am, working first for our Gynae Society, the president for the ISAR Uttarakhand chapter. We welcome you, Meenu ma'am. Aarti ma'am, we'd like you to say a few words after the welcome Aarti, please. Sahiti, do we have the welcome Aarti?
Yes. No question video. Go ahead, Saiti.
Aarti ma'am, would we like a few words from you, please?
Thank you. A very good morning to respected Purandre sir and good evening to all dear friends from India. It's so nice to see all the respected seniors, Dr. P.K. Shah, Dr. Jaya, and I would like to congratulate Dr. Sneha Bheur for collecting the galaxy of stars for this webinar, and all the topics are of clinical importance, which are going to help us all in improving our skills in managing obstetric conditions. Dr. Sneha Bheur, she's a great friend and a very dedicated Foxian, and I have known her for many years. I would like to read her CV, the salient points, although all of us, we know Dr. Sneha so well because of her active involvement in lots of Foxy activities. She has 32 years of experience in the field, and she has remained national faculty for HPV Master Trainer and State Coordinator, IMA Maharashtra. She has got National Individual Award by Foxy 2008, and she's got multiple appreciation award for her activities for public awareness, for being the National Adolescent Trainer, and for her exemplary work in cancer. Dr. Sneha has held the post of Chairperson Breast Committee in Foxy from 2019 to 21, and she had held many activities. I was the president Foxy at that time, Foxy Dehradun, and she visited our society and we did a grand program in the police line. I still remember, the nice initiative taken by her for the screening of breast cancer also. And she has remained the governing council member ICOG in 2021-22. Her dynamism is an example to follow. And now she is fighting for as the candidate for Vice President Foxy West Zone in the upcoming elections. I would like to invite Dr. Sneha to introduce about today's webinar, and I wish you all the good luck, Dr. Sneha.
Thank you. Thank you so much, Dr. Aarti. In fact, a very good evening to one and all. My respects and regards to all the seniors here, and a warm welcome to all the seniors and dear friends. Especially chief guest for today's program, Dr. C.N. Purandare sir, who is the past president of FIGO as well as Foxy. Guest of honor, Dr. Kiran Kurtakoti, who is the president of Amogs, and Madam Jaya Chaturvedi, who is the patron for Uttarakhand Society. Dr. Parag Biniwale, who is the ICOT chairperson and also the national coordinator for Amogs. Conveners, as you just heard, two beautiful ladies, my dear friends, Dr. Minu Vaish and Dr. Arati Luthra, and coordinator, my sweet friend, Dr. Radhika. Today's illustrious speakers and revered teachers, respected Dr. P.K. Shah sir and Dr. Murlidhar Pai sir, President Uttarakhand, Dr. Anupama Futela, my dear Madam Sarveshwari, Dr. Shweta Kaul Jha, Dr. Godavari Joshi, and all the chairpersons, including Dr. Arati Sharma, Dr. Madhu Kiran, Dr. Surabhi, and my dear esteemed panelists, Dr. Vibha Mehrotra, Dr. Manpreet Batla, Dr. Rajalakshmi Mundra, Pallavi, Anushri, Raval, and everybody, Sonal Jain as well. So I welcome all of you to this program, and I would just like to say that as a committee chairperson for Amogs Emergency, we are working not only to reduce the maternal morbidity and mortality, but also working on reducing the perinatal morbidity and mortality. This is just a humble attempt to go ahead with reduction in the perinatal mortality. Can we just mute
फरजाना
others?
मॅडमचा फोन येईल.
Can we
त्या
mute
साधारण
others
2:30 वाजता
slightly?
आपल्या बिल्डिंग वरून जाणार आहेत.
Yes, ma'am. Yes.
Please,
आणि काही
please
कागद आहेत
just
आमच्या क्वायरचे.
identify who is.
तर राजेशला तिकडे आपल्या पोस्ट बॉक्सच्या समोर
Can
जो
we
मेन
please
रोड आहे
request
ना गेटच्या
everyone
समोर
else to be mute while ma'am is talking, please?
So I would like to invite and introduce respected Dr. C.N. Purandare sir, who is our today's chief guest for this program, virtual program, but he's an inspiration for all. Sir, all of you know, as I have already said, is the past president of FICO as well as FOXY. I have witnessed him working as a FOXY president, and we are very thankful to him, inspiring and blessing people like many of like me. So, sir is the senior consultant in Mumbai at present. Sir is in New York and is the dean of ICOG, emeritus editor of Journal Obstetrics and Gynecology of India. That is Jogi, past president of FICO and FOXY, and past president of even the Indian College of Obsgyne. And sir has innumerable achievements and credentials to his credit. So I would just like to go ahead and request sir to bless us and guide us. Over to you, sir, for your precious words.
Good afternoon to you. It's good morning to me here. It's early morning, and I must thank Sneha for postponing the meeting by half an hour to accommodate my timing here early morning. I must say that Sneha is doing a fantastic job trying to get the knowledge across to so many. And we have today two fantastic speakers, and there is no way anybody can match PK Shah's work on fetal medicine and ultrasound, and of course Murlidhar Pai, who is now become the, I think, Vice Chancellor of the university there in Manipal. He was the Dean Provost before. So congratulations to both of them for being there in this program. And of course, the entire Amogs team, which is there with Kiran and with Biniwale and everybody. I think you have a full quorum here to be with the Uttarakhand Society, and I wish you all the very best for this program. And pardon me if I am not there the entire program here, but I will have to. It's very early morning here. We have to move out of the program because everybody is getting ready here to go to work in the house. So anyway, all the very best to you, Sneha.
Yeah. Sir,
Thank you, sir.
Thank you so much for your blessing, sir. Thank you so much. Indebted. Thank you. Over to you, Dr. Radhika.
We have with us Minu ma'am. Minu ma'am, will you please say a few words for the webinar? Ma'am, आप muted हैं, sorry. आपको unmute करना पड़ेगा, sorry. Sahiti, can we unmute ma'am? हाँ, हो गया.
Yeah. I'm really sorry I got late because of this net hitch,
It's
all
okay,
the problems in the networks. So
worry.
very good evening, everyone. And I congratulate all the working committee or organizing committee of Amogs for organizing this 52nd this thing, 52 edition of this conference on emergency obstetrics. So congratulations, Dr. Sneha, for conducting this webinar. We all know that this obstetrics, as an obstetrician, as a perinatal care provider, we all know fetal well-being is a core of obstetrician. And in any pregnancy, we need to take care of the fetal well-being, whether we are doing infertility, whether we are doing obstetric, whatever we are doing, the main purpose is to deliver a healthy baby to the mother. So with the time, with the advancement of technology, and with the advancement of new arising, evolving clinical guidelines, it has become very critical to have to survive this thing. Fetal surveillance has become very critical, and we need, in the era of the medical legal issues, we have to be very careful, and we all need to learn all fetal this thing, FGR, fetal surveillance, and what hematological disorder we are talking in this conference. This is very, very important. I welcome you all the panelists, and first of all, Dr. Radhika. She is the master of ceremony, and all the organizing persons in Amogs, Dr. Kiran Kurkoti, Dr. Dr. Vipin Pandit, Secretary Amogs, Dr. Rajendra Singh Pardesi, and Dr. Parag Viniwale, and most Dr. Sneha Bhuar. Dr. Sneha Bhuar is the chairperson, Emergency Obstetric Committee 2024 and 26. She was the chairperson, Foxy Breast Committee 2019 to 21, and she is the GCM ICOG. She's a very hardworking person and very good friend, and all the time connected to the academic sessions, and she is working for it. She is contesting for the post of Vice President West Zone. So we congratulate, and when we congratulate, all the best to you for your future endeavor, Dr. Sneha.
Thank you so much. Thank you, Minu.
I welcome all my friends, chairperson, Dr. Archana Luthra, Dr. Anupam Futela, Dr. Shweta, Dr. Aarti Sharma, Dr. Madhu Kiran, and Dr. Sarveshri ma'am. She is always guide to us, Dr. Surabhi, and all the panelists, Dr. Vibha, Dr. Manpreet, Dr. Rajlakshmi, Dr. Anushri, Ruchi, Ishna, and Sonam, and Dr. Achal. So, congratulations again, Dr. Sneha, for such a wonderful webinar. Over to you, Dr. Radhika.
We are blessed to have a galaxy of stars with us here today. And amongst the two of the people I would love to introduce are our guests of honors. One, we have Dr. Kiran Kurkoti, sir, who's the president of Emogs. Sir, thank you so much for sparing your precious time to be with us. Sir needs no introduction. He has numerous awards and numerous work.
Radhika ji, thank you. Radhika ji, thank you. At the outset, thank you, Sneha. Why thank you? Because you are taking us all around India. Because yesterday you took us to Bangalore or Kasoga. Today we are at Uttarakhand. So दक्कन का जो आदमी रहता है ना, उसको जब उत्तराखंड पहुंच जाते हैं ना, तो ऐसा बहुत ऐसा ठंडी हवाएं लहराती है आजू बाजू में. So हमेशा see, it's a lovely memories of Uttarakhand. So thank you, Sneha, for that guided all India tour of Amogs, and thank you for bringing CN Purandare sir on this particular forum. I think this is the first time we are having CN sir right now, as far as this season is concerned. Thank you so much, and my respects to Dr. Jaya Chaturvedi ji, Dr. Meenu Vaish, and of course I see a lot of friends, Rameshwari madam, Aarti, and Dr. Ishna, of course Meenu Vaish is my Vaish madam, Parag is also there, and
Vishal sir.
Thank you, Sneha. And as CN sir rightly said, that two stalwarts. I mean, I don't regard Murlidhar Pai now as a Kasoga person, because we have already called Murlidhar so many times in Amogs. Last time, in fact, in the last Amogs, he gave this oration also. So Murlidhar is now, I mean, in case there is some position for Dr. Murlidhar Pai in Maharashtra, I think we will allocate it to him. So thank you for bringing Murli, of course. And of course, PK Shah, my one of the most favorite Foxy presidents. We have been meeting so often, sir, that you have brought sir so many times in this webinar and series that, and it's really lovely to hear from sir wherever it is ultrasonography, anything that matters, sir is always there. So thank you for bringing this galaxy of speakers to us. Thank you for taking us to Dehradun. My best wishes to you. My best wishes to Shweta Kaulja also. I see Shweta there also. Thank you so much. And hope we shall pray that Uttarakhand also stays with Amogs wherever Amogs needs it. And whenever Uttarakhand needs Amogs, we are there. So thank you so much. And with that, I would request you to get on with the talks. Thank you so much.
Thank you, sir.
Thank
I
you.
will just take half a second more because I will not skip this opportunity to introduce our second guest of honor, which is a privilege for me to introduce her. She is Dr. Jaya Chaturvedi, ma'am, the Dean Academics at AIMS Rishikesh, the professor and HOD at the Obs and Gynae department there, and the backbone of the department. And I've been blessed to have been taught by her. I've got my MBBS degree under her. I wouldn't skip this opportunity to introduce you, ma'am. You've given us time from your busy schedule. Please bless us with a few words, ma'am.
Yes. Thank you, Radhika. Thank you so much for inviting me and introducing me. So, good evening, everyone, and good morning, Purandre sir. First of all, I congratulate Amogs and Uttarakhand societies to tie up for this important webinar, which is covering very important topics today: FGR, antepartum surveillance, and hyperglycemia in pregnancy. This is the brainchild of Dr. Sneha Bhuyar. She is working on it on this webinar series, and this is the 52nd episode we are going to listen today from the stalwarts. We are having Purandre sir and PK Shah sir, who guided the Foxy and is still enlightening us. They are continuing giving us good academic fees. So, sir, thank you for everything which you have given to all of us. Dr. Kiran, Dr. Parag, I met Dr. Parag recently in Ambala. So, and everybody, all the office bearers from Amogs, I thank you all for conducting so good series of webinars continuously and tying up with other states also. So without wasting much time, I am seeing a lot of panelists, conveners, everybody who is known to me. They are more closer to my heart. All the Uttarakhand consultants who are here on the screen. So I wish you all a very good academic feast today. And thank you so much.
Thank you so much, ma'am.
Yeah, thank you so much, madam, for your precious words and, of course, words of guidance as well. I would like to invite our dear friend, Dr. Parag Biniwale, who is not only the ICOG chair, but also the national coordinator for Amogs. And all of you know him so well. So I think we just would like to go ahead with listening to him. So over to you, Parag, for your words of wisdom.
Yeah, thank you, Sneha. Good evening. I bring greetings from Amogs, and it's indeed a pleasure to be interacting with the friends from Uttarakhand. Sneha, I must appreciate the efforts put in by you and your committee, the Emergency Obstetrics Committee of Amogs, because you've crossed boundaries and you are connecting to doctors beyond Maharashtra. And it is an important exchange of knowledge where we get to listen to very popular teachers. In fact, two of the best teachers in the country, I would say, Dr. PK Shah and Dr. Muralidhar Pai, who will be talking about fetal growth restriction and fetal surveillance. And all our friends from Uttarakhand will be discussing along with you as a moderator on hematological disorders. So I'm sure it's going to be a great learning experience for all of us because you are covering very important topics. My best wishes for the webinar, and Sneha, best wishes to you for your forthcoming elections too. Thank you very much.
Thank you, sir.
Thank you, Parag. Thank you for all your, very precious words and your best wishes, of course. Thank you so much. I thank, with the blessings of God Almighty and the blessings of all the respected seniors and guests of honor, we would like to move ahead with the academic session soon. And for this, I would like to hand over to Dr. Radhika.
Thank you, ma'am. We have with us a very dynamic personality from Foxy. Sir has held many numerous positions, important positions at Foxy. Dr. PK Shah, sir, we welcome you for your talk. And we have three beautiful ladies to chair your session. One being my president from Uttarakhand Societies, Dr. Anupama Ravi Futela ma'am. She'll be joining us shortly. Dr. Shweta Kaul Jha ma'am, she's been kind enough to join us for this webinar as a chairperson. Welcome, Shweta ma'am. And respected Godavari Joshi ma'am, the head of department, GMC Medical College, Haldwani. And I would kindly request Dr. Shweta ma'am to please give a brief introduction about sir.
Has Dr. Anupama come, or shall I go
I
ahead?
think ma'am will be just joining us shortly.
Okay.
I would
Okay.
request you to
Go
please.
ahead with the introduction, Shweta.
Okay. It is my proud pleasure to introduce Dr. P.K. Shah sir, and he was professor and unit head of Department of OBGYN and at LTM Medical College, LTMG Hospital, Sion, Mumbai, St. GS Medical College, KEM. He was the past. Sir, just little few lines. Past President Foxy, IAG, IFUMB, MOGS, AFTT, past Dean, Indian College of Medical Ultrasound, past Chairman, Imaging Committee, past Chairman, ISOPAR, Joint Secretary, IMAGE, Fellow, International USA, WellStart, Foxy, Representative to AFOG, past Editor, OBGYN Journal Today, Co-Editor General of IFUMB, and member of several committees, and has more than 700 lectures till now delivered, and a lot of publications and orations and awards like Lifetime Achievement Award by Foxy and various other organizations. It is our proud pleasure to have you, sir, here today. Welcome.
Thank you. Thank you very much for your kind words. Can I share my slides?
Slide.
Yes, yes. Sure. Welcome, sir.
Can you see? Can you see the slide?
Yes, sir. Yes.
Okay.
Yes, sir. We can see it, sir.
So, good evening, everyone, for bringing USA and UK. CN from USA and Uttarakhand. It's a great pleasure to be a speaker in your webinars. And I thank Amogs, especially Dr. Kiran Kurtukoti, Dr. Bipin, Dr. Rajendra Singh Pardesi, Dr. Parag Biniwale, Dr. Madhuri, and obviously the chairperson of Emergency Obstetric Care, Dr. Sneha Guyar, who is contesting for the Vice President's post from West Zone in the election year 2025. I wish her all the very best and success. Nice to see senior like Dr. C.N. Purandare as a chief guest, Dr. Kiran Kurtukoti and Dr. Jaya as guests of honor. Shall I start my talk now? Okay.
Yes, sir, please.
One must remember the causes of placental insufficiency, like maternal hypertension, thrombophilic disorders, APLA, chronic nephritis, SLE, diabetic microangiopathy, post-term pregnancies, placental implantation of fibroid vasculoplasm, etc. We have given up the terminology IUGR. We don't use it, we call it as FGR, fetal growth restriction. Fetal growth is a result of maternal availability of nutrients, placental transfer, and fetus's own growth potential. In fetal growth restriction, the fetus doesn't succeed to reach its own growth potential. When you have a birth weight less than 10 percentile, we call it as small for gestational age. There are two things in SGA. One is genetically small, like a constitutionally small fetus, born to a small lady, weight-wise, height-wise, but it's a healthy small for gestational age, wherever you'll find Doppler normal. Whereas a fetal growth restriction, the baby fails to achieve its own growth potential. The Indians are small and small Indians have smaller babies. 50 to 70% of fetuses are constitutionally small, whereas fetal growth restriction rate is around 30%. How do you define that estimated fetal weight less than 10 percentile as per American College and Royal College? Based on BPD, HC, ACFL, etc., you call it small for gestational age. Whereas if the estimated fetal weight is less than third percentile, As said by WHO, you call it as fetal growth restriction. And FGR is the most common cause of premature birth and intrapartum asphyxia. Now, there is an extension of definition of fetal growth restriction, whereby it includes three parameters. One, estimated fetal weight less than third percentile, cerebroplacental ratio less than fifth percentile, and uterine artery PI more than 95th percentile. So the fetal growth restriction is equal to estimated fetal weight less than 10 percentile plus any one of these 1, 2, 3. Overall frequency of fetal growth restriction is around up to say 8%. 30 to 50% of extremely preterm neonates are also fetal growth restricted. It's responsible for almost 50% of perinatal mortality. So what is the pathophysiology of uteroplacental causes? It's absent of physiological changes in some segments of spiral arteries, whereby the trophoblasts don't eat up the adventitia of the spiral arteries, and hence the increased resistance continues. There is inadequate trophoblastic invasion, absence of uterine artery vasodilatation, reduced placental perfusion, hampered venous microcirculation, umbilical hypoxemia, and vascular changes for compensation. Growth-restricted fetuses have an augmented risk of mortality and morbidity because of intraventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, infections, pulmonary hemorrhage, and hypothermia and hypoglycemia. When you have a fetus with weight less than 10% of the value for the pregnancy age with an increased HCAC ratio, please remember this, keep it in mind. FGR diagnosis implies evaluation of the fetal weight by ultrasonography. So the ultrasound diagnosis of fetal growth restriction steps in appropriate evaluation. Number one, assign fetal age. Very, very, very important. Assess size of the fetus, estimate fetal weight, do amniotic fluid assessment, do color Doppler, biophysical profile, and rule out congenital anomalies. So when you have a fetal growth restriction and placental dysfunction, what do we monitor? To monitor the growth, you have biometry and growth charts. Not a single one, but multiple, serial. Fetal compensatory mechanisms, you use Doppler. For predicting hypoxemia and acidemia, again you use Doppler. And for the environment, you have AFI, CTG, biophysical profile, and placental study. Now, we all know we used to do measurement of the symphysiofundal height, abdominal girth, etc. And we all know that the fundal height increases by 1 centimeter per week between 14 to 32 weeks. And if there is a lag in fundal height of 2 weeks, it's a moderate FGR, whereas if the lag is more than 4 weeks, then you call it a severe fetal growth restriction. Unfortunately, clinical evaluation has very low sensitivity up to 44%, and hence we don't rely on it. So to establish gestation age, first trimester crown rump length is the most accurate means of dating. And I'm sure all of us know now how to do crown rump length. Then comes the sonographic evaluation of fetal biometry, biparietal diameter, head circumference, transverse cerebellar diameter, abdominal circumference, humeral length, measurement ratios, very important. The BPD and femoral length are less modified. Most affected in all these parameters is the abdominal circumference. Comparison with standard growing curves and calculation of percentile is very important. Serial evaluation of the fetus and calculation of individual growth curves, dynamic evaluation of the fetal growth, the trend, and the identification of a slowing or stopping of the growth is very important. This is very, very, very important. You must have these charts and see that every time you do this BPD, etc., you please enter into this and see what is the trend. Next thing is the measurement ratios, the head circumference divided by abdominal circumference. If it is more than 2 standard deviations above the mean, it is predictor of fetal growth restriction. Whereas FL by AC, if it is above 23.5%, it is considered as abnormal and think in terms of fetal growth restriction. We all know that the color Doppler detects deterioration of fetus 10 to 15 days before modalities available to us that can detect intrauterine fetal distress, like cardiotocography, fetal biophysical profile. The color Doppler, we try to find out causes where CTG, FBB, etc. defect the effect, and hence it is better to detect cause than to wait for its effect to prevent delay in management. So what is the role of Doppler in fetal growth restriction? To identify etiology, whether it is placental or non-placental, to identify hypoxia and fetal adaptation, plan timing of delivery, and to identify fetus is at risk of perinatal complications. To identify vascular weight resistance, you have to do uterine artery Doppler and umbilical artery Doppler. And to identify fetal adaptation, you have to do middle cerebral artery Doppler. And to identify cardiac decompensation, you have to do ductus venosus and umbilical vein. Now, how frequently are you going to monitor this fetus? The frequency is dictated by severity of growth restriction and gestational age of the fetus. You can do biometry every 2 weeks at least. No value for biometry if the interval is less than 2 weeks. And Doppler again every 2 weeks if mild, and then weekly, bi-weekly, and even daily if severe dysfunction. AFI also can be done weekly or twice a week. That's a uterine artery Doppler in first trimester. It has high resistance, so don't worry about that. It's normal. As the pregnancy advances and she goes into the second trimester and third trimester, the end diastolic flow keeps increasing, which is very heartening. SOGC has given clinical guidelines for uterine artery Doppler because it can be performed between 70 to 22 weeks if she has high risk factors. Remember one thing, the persistence of notch in uterine artery is no more important. It is a PI of uterine artery at that period of gestation is important. Then comes a cerebroplacental ratio, CPR. It is middle cerebral artery PI divided by umbilical artery PI. CPR is the single most sensitive parameter for assessment of the fetal growth restriction and has a single cutoff value of 1. Uterine artery Doppler is important at 20 weeks, umbilical artery, MCA, aorta, and ductus venosus after 38th week of gestation, and ductus venosus Doppler between 11 to 14 weeks and after 30 weeks. Fetal aorta flow resistance should decrease with gestation. In fetal growth restriction compensation, there is less flow in the aorta because of high resistance, and this less flow to kidneys decreases the GFR, glomerular filtration rate, which leads to oligohydramnios, and less flow to coronaries and abdominal viscera will lead to fetal origin of adult diseases. Ductus venosus has 3 forward waves. The reversal of third wave in third trimester, that we call as A wave, immediate action has to be taken. Reversal of third wave in first trimester goes in favor of chromosomal anomalies. That's a normal M-shaped wave that you see. This is the A wave. This is the ventricular systole, diastole. This is the atrial systole here. And if you have a reversal like this, you know you're dealing with the fetal growth restriction in third trimester. There are 2 types of fetal growth restriction, EFR, early fetal growth restriction, and late fetal growth restriction. They are distinct by the moment of onset, evolution, Doppler parameter modification, and postnatal outcome. The best cutoff between these 2 forms of fetal growth restriction is 32 weeks. There is something called as the early fetal growth restriction Delphi consensus. What is it? Gestational age less than 32 weeks, no congenital anomalies, and the AC or estimated fetal weight is less than 3rd percentile, and the umbilical artery will show absent end diastolic flow, or abdominal circumference estimated fetal weight less than 10 percentile combined with uterine artery PI more than 95th percentile, 95th percentile, and the umbilical PI also more than 95th percentile. For late fetal growth restriction, the Delphi consensus says that the gestation age is more than 32 weeks in absence of congenital anomalies, and the abdominal circumference and estimated fetal weight less than 3rd percentile, or at least 2 out of 3 of the following: AC, EFW 10 percentile, AC, EFW crossing centiles, and CPR less than 5th percentile or umbilical artery more than 95th percentile. Early onset fetal growth restriction is determined by massive lesions or dysfunctions of the placental structure taking place during first and second trimester of pregnancy due to inappropriate trophoblastic invasion of the spiral arteries. Early FGR is considered to be a vascular disorder due to abnormalities of the tertiary venous vessels. As you can see here, normally this is what should happen, and it does not happen because of trophoblastic invasion not occurring. It is more frequently encountered in patients with preeclampsia, autoimmune disorders, and conditions that can affect the placental vessels. But late onset FGR is not connected with preeclampsia most of the times. In early FGR, evolution is long enough to permit the development of a classical fetal asymmetrical hepatopy that can be diagnosed by ultrasound. This long evolution is mainly due to small oxygen demands of the fetal brain and to long resistance to the hypoxia of the fetal heart at this age of gestation. So there is a sequence of classical progressive Doppler alteration in early onset FGR. Abnormal blood flow in placenta due to vascular lesions and increased vascular resistance. It leads to increased resistance in the umbilical arteries, determining peripheral fetal vasoconstriction and augmented umbilical artery PI. Cerebral vasodilation will occur with reduction of middle cerebral artery PI. This is a compensatory mechanism. Then you will see absent end-diastolic flow or reversal of end-diastolic flow in umbilical artery, abnormalities in pulmonary and aortic outflow tracts with cardiac insufficiency. And now, with the overload of the precordial venous system, the A wave is either absent or reversed in ductus venosus. This is what happens from right beginning till end. There's a normal umbilical artery flow. This is an increased resistance, less and less flow in the end diastolic flow. Absent end diastolic flow in umbilical artery. This is a reversal of flow in umbilical artery. This is again a reversal of flow in umbilical artery. What a predictive value of umbilical artery waveform indices. If impedance is increased in umbilical artery, more than 60% of the placental vascular bed is obliterated. Absent end-diastolic flow and reversal of end-diastolic flow in umbilical artery are associated with 40 to 70% of peritoneal mortality, respectively. That is a middle cerebral artery, high resistance, normally. But if you see less resistance as a compensatory mechanism in early growth restriction. MCA-PI, if it is less than 5th percentile, it is an efficient tool for evaluation of the cerebral vasodilatation. CPR less than 1, regardless the evaluation methods is associated with poor perinatal outcome. In early FGR, umbilical artery will show you high resistance, high PI. MCA will show you compensatory mechanism with low resistance. Cerebral placental ratio should be considered as an assessment tool in fetuses undergoing third trimester examination, regardless of finding of umbilical artery and middle cerebral artery Doppler. There are discussions about the utility of routine third trimester Doppler ultrasonography. Even if you feel that all is well, please, if you are doing ultrasound in third trimester, which is a must for growth, also combine it with Doppler. Ductus venosus normally has this M shape, and then you have a reversal coming up. This is again a normal ductus venosus. And then when you have a reversal like this, you know that this is something which is very serious for the fetus, and you must get this fetus out. M shape, systolic, diastolic, and then atrial contraction wave. If it is reversed, to get that baby out as early as possible. Ductus venosus flow Doppler is a useful parameter since all the precordial veins. Ductus venosus allows most accurate interpretation of fetal cardiac function as well as myocardial hemodynamics. Aorta also has a increased resistance over a period of time as the pregnancy advances, resistance decreases. But what is more important, which comes up before ductus venosus changes, is the aortic isthmus PI. It is increased, and the absolute velocities, especially time XV, are reduced in intrauterine growth restricted fetus, is the fetal growth restriction. You'll find it increased resistance in this also. So what is the timeline for hypoxemia of the fetus? Abnormal fetal growth, abnormal arterial Doppler. Within 2 weeks' time, we'll find abnormal venous Doppler, and within a day or two, you'll find abnormal cardiotopograph and physical profile score. Late onset fetal growth restriction represents the failure of the fetus to reach its growth potential at term. In most cases, the placental lesions have a late onset and or do not have a significant extent in order to increase the resistivity of the placenta and translate it into augmented umbilical artery PI. Lesion is there, but it is not severe enough to have changes in the umbilical artery. In late FGR terms of frequency, it is far more prevalent, 80%, than early onset FGR, which is 20%. It has placental abnormalities like venous immaturity with less impact upon placental resistance. Therefore, the umbilical Doppler indices can be unaffected in late onset growth restriction. Diagnosis is more difficult due to large variability of fetal parameters on growth charts in third trimester. In fetuses with late onset FGR, estimated fetal weight appears to remain many times within limits or appropriate for gestational age at more than 10%. Late onset FGR can be suspected when individual growth curve slows down or even becomes flat, and there is an increase of HCAC ratio in a previously normal growing fetus. Now, this gives you a suspicion. Fetal brain at term has increased requirement of oxygen. Therefore, the first hemodynamic alteration in presence of hypoxia is cerebral vasodilatation. This method of neuroprotection cannot completely compensate the effect of hypoxia. Cardiac insufficiency does not have enough time to arise the severity of the cerebral lesion taking place faster and determining severe CTG alteration. Therefore, the classical sequences of Doppler modification which you see in early onset, they are not present in late onset fetal growth restriction. During last 20 weeks of pregnancy, brain increases in size by 17 folds. Late onset FGR fetuses are very fragile due to increased oxygen requirement of the brain. They present multiple risks due to their inability to tolerate hypoxia. Reactive cerebral redistribution in late onset FGR fetus is associated with an alteration of the brain metabolism. Undetected fetal growth restriction in third trimester of pregnancy represents the main cause of unexplained stillbirth in low-risk pregnancies. Also, probably a number of idiopathic cases of cerebral neonatal palsy where an acute intrapartum hypoxic event could not be identified are in fact caused by undetected late onset fetal growth restriction. Don't think ultrasonography is not important in third trimester. Please do it and also combine it with color Doppler. Doppler markers of cerebral vasodilatation seem to be a landmark of late onset FGR. If the middle cerebral artery PI is less than 5%, is considered a marker of cerebral vasodilation, even in presence of normal umbilical artery PI. If in the third trimester, the obstetrician analyzes only umbilical artery PI, these fetuses, the late onset, will be missed, and the potential intrapartum postnatal complications cannot be anticipated. Late onset FGR fetus is at a higher risk of cardiovascular disease, hypertension, glucose intolerance, diabetes, dyslipidemia, obesity in childhood, and even in adulthood, all these diseases. The rates of acute fetal distress during delivery and number of emergency C-section in late onset FGR with cerebral redistribution are significantly increased. Recent guidelines recommended delivery of FGR fetuses with brain sparing effect because of its predictive of acidosis at birth. Cerebral redistribution may be used in association with other clinical ailments in the decision of delivery of late onset fetuses, even in presence of normal umbilical artery Doppler. After 34 weeks, the risk of serious morbidity and mortality is low, and the delivery of the fetuses with LFGR will minimize the long-term sequelae. The paradigm that a normal umbilical artery Doppler pattern in third trimester confirms normal pregnancy doesn't need any further Doppler evaluation of the other fetal vessels definitely needs to be modified with important impact upon clinical follow-up. So how do you correctly diagnose? Number one is clinical, only low sensitivity, accurate gestation, very, very, very important. Fetal abdominal circumference, if it is less than 5th percentile, fetal growth velocity, if it is less than 1.5 standard deviation in 2 weeks' time, AFI less than 5th percentile, and abnormal Doppler findings, as I already told you. Now, how do you manage? Now, it's very simple that we have now stage-based management of fetal growth restriction of early onset. This is for early onset. Stage 1, what is the pathophysiology correlate? Severe smallness or mild placental insufficiency, estimated fetal weight less than 3rd percentile, cerebroplacental ratio less than 5th percentile for that period of gestation, umbilical artery PI more than 95th percentile, uterine artery PI also more than 95th percentile. How often do you monitor this baby? Every week. When and at what gestation will you deliver? 37th week of gestation or beyond, and you can do induction of labor. There is no need of doing C-section if there is no indication. Stage 2, severe placental insufficiency. How do you find out? What are the criteria? Umbilical artery showing you absent end diastolic flow, and there is reversal of aortic isthmus Doppler. How often you monitor? Twice a week. When do you deliver? 34th week. What is the mode of delivery? C-section. Stage 3, low suspicion of fetal acidosis. How do you find out? What are the criteria? Umbilical artery shows you reversal of end diastolic flow, and the ductus venosus PI is more than 95th percentile. How often you monitor? Almost daily. When do you deliver? Anytime after 30 weeks. By C-section. And stage 4, high suspicion of fetal acidosis. Ductus venosus showing you reversal of third wave, that is A, atrial contraction wave, with CPG less than 3 centimeter and fetal heart rate deceleration. You can do monitoring every 12 hourly, deliver after 26 weeks by C-section. Antepartum surveillance protocol includes late onset FGR, mild placental insufficiency, fetus less than 10%, threatening of the growth curve in third trimester, after 32nd week, normal umbilical artery Doppler, low PI in mid-cerebral artery, and cerebroplacental ratio less than 1. Uterine artery Doppler may be abnormal, like either normal or low, not associated with preeclampsia. Monitor weekly Doppler growth and LIPO. Antepartum surveillance protocol for late onset fetal growth restriction, gestation age more than 37th week, deliver. Allow vaginal delivery. If it is less than 37th week, you can give steroids. Doppler of uterine artery, if it is more than 95%, or CPR less than 1, and estimated fetal weight less than 3rd percentile. If any one of the above 3 abnormal, consider delivery. Monitor for serial worsening of middle cerebral artery beyond 95th percentile. The optimal gestation age to deliver fetus with LFGR is more than 34th week, delivery at 37th week, with increased PI of umbilical artery, delivery between 37-38 week, in cases with normal umbilical artery Doppler with modified middle cerebral artery. The timing of delivery is based on middle cerebral artery Doppler only. In cases with normal umbilical artery Doppler with abnormal umbilical artery PI, but end diastolic velocity is present and good obstetrical condition, induction or labor can be offered, but rates of C-section are very high. Early admission is recommended in women in spontaneous labor with small gestational fetus in order to instigate continuous fetal heart rate monitoring as said by IFCW. fetal heart rate monitoring will be interpreted more cautiously than usual. So I have not concluded my talk, but it is for late onset FGR. Onset after 32 weeks, BIH need not be there. High index of suspicion. Umbilical artery Doppler may be normal. Always combine umbilical artery with MCA and CPI for decision making. Mode of delivery, fetuses with significant growth restriction should be preferably delivered in well-equipped center that can provide intrapartum continuous fetal heart rate monitoring, fetal blood sampling, and expert neonatal care. Vaginal delivery can be allowed as long as there is no obstetric indication for C-section and fetal heart rate is normal. Fetuses with major anomaly incompatible with life should be delivered vaginally. When do you do C-section? In all cases of fetal growth restriction, features of acidosis, cesarean section should be done without trial of labor. This includes repetitive late decelerations, poor biophysical profile, reversal of end-diastolic flow in umbilical artery, abnormal venous Doppler, blood gas analysis showing acidic pH on chordocentricity. But what is more important is treatment that does not work. I think all of us feel by giving so many things, thinking that something will work. It does not work. And I must tell you, what does not work includes bed rest, maternal oxygen supplementation, maternal nutritional supplementation, low dose aspirin, beta blockers, calcium channel blockers, plasma volume expanders, nitric oxide donors, L-arginine, vitamin C, Viagra, etc., etc. They don't work at all. The factors which influence scan or growth of the fetus, the operator's experience, skill and training, resolution of your ultrasound equipment, time allocated for scan, types of malformation, major, minor, single, multiple, gestation age at which you are doing ultrasound examination, and length and accuracy of follow of after birth. What are the take-home message? Differentiate between constitutionally small and fetal growth restriction by composite growth curves like Kerr and Doppler. Many so-called constitutionally small babies will be redefined as fetal growth restriction, adding CPR, uterine artery Doppler, and estimated fetal weight below third percentile. Doppler of umbilical artery MCA, ductus venosus, and aortic isthmus are useful for monitoring and timing of delivery of fetal growth restriction. Pathological growth restriction fetuses have higher morbidity and mortality rates and hence require more intensive surveillance. Thank you very much, ladies and gentlemen, for your patient hearing. And I don't know whether I'm supposed to ask questions or not, but if you have any questions, you can ask me.
Thank you very much, Shah sir, for a very clear and concise presentation and such apt go-to points that we may all use in our day-to-day clinical practice. I would request our chairperson, Dr. Godavari Joshi, ma'am. Ma'am, are you with us? Godavari, ma'am?
Yes. Good evening,
Ma'am,
everyone.
please have a
Yes.
few pearls of
Good
wisdom
evening,
from you.
everyone. Thank you for the opportunity. It was an outstanding deliberation by Dr. P.K. Shah, sir. And as we see many cases in our clinical practice, in day-to-day practice, and we are always in dilemma how to diagnose what clinical method we should use, the stages of the IUGR, whether it is early onset or the late onset. And sir has explained very nicely everything about this. And the mainstay in the diagnosis is the color Doppler. As sir has said that it is the PI of the MCA and the CPR is very important for the diagnosis. And for this Doppler, we should first assign the gestational age. That is very important, and using the growth chart. That is, these two things are very important. And the last is the, as sir has said, for the delivery, the decision to deliver, that is very important, so that we can reduce the perinatal mortality by 40%, as it is seen in the late pregnancy. Intrauterine death is because of the late onset fetal growth restriction. So it was a great learning, sir. Thank you very much.
Thank you.
Thank you very much, Godavari ma'am. And once again, thank you very much, PK Shah sir, for an excellent talk as always. And thank you for blessing the Uttarakhand societies with this opportunity. And thank you to Sneha ma'am for giving this to us. We now move ahead with our second session. We have a very, very sound academician as a speaker, Dr. Murlidhar Pai, sir, the Dean and the Vice Chancellor for the Sikkim Manipal University. Sir, it's a pleasure and an honor for us, Uttarakhand societies, to have you with us. And to chair your session, we have very seasoned and very learned chairpersons, Dr. Meenu Vaish ma'am, who's the President ISAR Uttarakhand chapter, Dr. Aarti Sharma ma'am, professor at the SGRR Medical College, Dehradun, and Dr. Madhukiran ma'am, who's the president for the Haldwani Obs and Gynae Society. I would please request Dr. Aarti ma'am to kindly introduce Dr. Murlidhar Pai, sir.
Thank you, Radhika. Good evening, everyone. It is my immense pleasure to have Professor Dr. Murlidhar V. Pai today among us for discussion on the fetal surveillance. Sir is Dean, Sikkim Manipal Institute of Medical Sciences, Sikkim, and he is Professor of Obs and Gynae. He has 37 years of experience in academics, 25 awards, 15 international fellowships, 207 publications, 3 textbooks, and oh my God, 835 guest lectures. So, most welcome, Murlidhar V. Pai, sir, in this today's discussion about the fetal growth restriction and fetal surveillance. And I welcome you here for your expert talk. Thank you.
Thank you so much, ma'am. Thank you, Dr. Radhika, for the introduction as well. And I will upload my talk now, and I will straight away start talking. Yeah. I hope my slide can be seen.
Yes, sir.
Yeah. Thank you so much. What I would do is, thank you, Dr. Sneha, for always inviting me.
Sure.
And I wish you again very best in your next endeavors. What I have decided is, instead of going for fetal surveillance, which Dr. PK Shah sir has very nicely explained as far as FGR is concerned, I will concentrate on intrapartum fetal monitoring, which is also a very important aspect once you have decided to deliver, because the treatment of FGR, as correctly told by PK Shah sir, that no treatment works except the timely delivery. Now, once you have decided to deliver vaginally, whether it is FGR or any other babies, it is very, very important for us to do a proper intrapartum fetal monitoring. So I would be concentrating on that. The CETON multidisciplinary work group has very clearly told the highest risk for obstetric harm are 5. Number 1, injudicious use of oxytocin. We must always avoid that. I'm putting it in an order so that you will understand very easily. The first thing is uterine contractions, isn't it? So here, injudicious use of oxytocin will lead to fetal distress. The second thing, let us say, whatever it is, fetal distress has occurred. The problem is mainly due to failure to recognize fetal distress. So that is where my talk will be really centered today, how to recognize fetal distress. Then, of course, once you recognize fetal distress, depending upon the stage of labor, you have to use appropriate instrument, either a vacuum or a forceps, to hasten the delivery of the fetus so that fetus does not suffer much. But if the distress has occurred earlier than second stage, we should not hesitate to take her up for an emergency cesarean section. In other words, failure to perform a timely cesarean section also is the cause of obstetric harm. And finally, we have to promptly and properly resuscitate asphyxiated baby. So what is in our hand? Of course, avoiding injudicious use of oxytocin, but most importantly, recognition of fetal distress and taking appropriate step. If she's in late second stage, an instrumental delivery. In the first stage, a emergency cesarean section. The last part is, of course, that of a neonatologist. So I'm going to concentrate today on failure to recognize fetal distress. In other words, how to recognize fetal distress. What is the goal? The goal is to detect developing fetal hypoxia. We should not be detecting when everything is over. We should detect as early as possible as the hypoxia is developing to prevent subsequent acidemia, because acidemia is the one finally harms the baby more than hypoxia. And what more, long-term irreversible neurological damage in the newborn. You may somehow hook or crook deliver the baby, but the baby has got a permanent neurological damage, which is not acceptable. So let us understand what is the normal parturition. The normal parturition itself is an asphyxiating event. Imagine every now and then somebody is pressing on your face with a pillow. That's exactly what happens to the baby. Every now and then, intermittently, at least 3 times in a 10 minutes, which is a normal labor, there is severe uterine contraction, which is almost like pressing the baby with a pillow. So normal parturition itself is an asphyxiating event. That is during the contraction. There is a decrease in the uteroplacental blood flow, and there is decrease in partial oxygen as well as pH. And there is increase in fetal partial carbon dioxide. So this is a perfect recipe for asphyxia. It happens in a normal labor. We should understand that. However, what happens in normal labor, the levels do not fall outside the critical threshold. That's why, and of course, all of us know that the contractions do not last more than 40 seconds, wherein the baby has time to immediately recover if the fetus is healthy. If the fetus doesn't have FGR, if the fetus doesn't have long-term chronic asphyxia or hypoxia, or if the fetus is not preterm fetus and it is simply a healthy term fetus, the baby can definitely withstand the strongest of all the uterine contractions. Labor contractions should be normal. It should not be an abnormal uterine contraction which lasts for more than 40 seconds, or it comes more often than 3 in 10 minutes. Placental reserve is adequate. Again, if there are placental calcifications or if the placenta is over-matured, then also baby cannot withstand. Fetal distress is likely to occur with compromised fetus, which I already told you, despite normal uterine contraction. What is a compromised fetus? A fetus with FGR, a preterm fetus, or fetus which has gone through a chronic hypoxia because of placental insufficiency, for example, in preeclampsia, or exaggerated uterine contractions despite healthy fetus and adequate placental reserve. Suppose the baby is healthy, but contractions are incoordinate, they are excessive, lasting more than 1 minute maybe, and it is coming very frequently. That is also bad. What are the methods to detect fetal distress? Of course, the time-tested method is intermittent auscultation. This has been there from time immemorial, and even today in 2025, it is still good enough. Of course, since last 60 years, we have been using electronic fetal monitoring, which is obviously better than our auscultation in certain situations. For example, high-risk babies, where you can continuously monitor these babies. Now let us look at how EFM has fared versus intermittent auscultation. Compared to intermittent auscultation, EFM results in higher operative vaginal delivery rates. Why? Because it can pick up the fetal distress more than the auscultation. So we tend to use instrumental delivery more. and of course, increased rate of cesarean delivery. But it is worth as long as you get a normal, healthy baby without any acidemia or without any neurological damage. That's why, though there is a increase in operative vaginal delivery, increase in cesarean delivery, we cannot discard EFM or we cannot blame EFM. In fact, we have to thank EFM. But this is the line which is captured everyone's imagination without significant reduction in perinatal mortality. So that goes to say both EFM and intermittent auscultation are almost similar, provided the person behind them is sincere, that is a doctor. Even NICE guidelines say there was no apparent difference in perinatal death rates between the two groups, that is EFM group and intermittent auscultation group. Enough to say that both are equally good, provided we are careful, we are good. Now let us look at ACOG and AAP 2012. How did they fare? Intermittent auscultation is good enough in low-risk pregnancies, whereas in high-risk pregnancies, it is good, but there's a bracket, small letter A. That means before, during, and especially after contraction for 60 seconds, which means intermittent auscultation is fine, which is once in 15 minutes, but you have to do it before contraction, during contraction, and for 60 seconds. It's not just you count it for 15 seconds and multiply by 4. You have to really auscultate for 1 minute starting from before contraction. Continuous fetal monitoring, of course, is okay for low-risk pregnancies, but it is definitely indicated in high-risk pregnancies. It includes evaluation of tracing every 15 minutes. It's not just you connect the EFM and go for a coffee. You have to sit there, you have to evaluate every 15 minutes, and you have to inform the concerned seniors. Otherwise, it is of no use. Evaluation intervals, of course, for first stage, it is 15 minutes for both intermittent auscultation as well as EFM, and for both low risk as well as high risk pregnancies. As far as second stage is concerned, it is once in 5 minutes, because second stage is a shorter stage and a lot of changes are happening in second stage. The baby is, going through the pelvic canal. It does a lot of rotation. Whole mechanism of labor is happening in second stage. Now, continuous electronic fetal monitoring is, as I said earlier, indicated in high risk for fetal hypoxia and acidosis. So what are those? Previous cesarean section, as far as maternal problem is concerned, preeclampsia, PROM, multiple pregnancy, medical disorders, APH, maternal pyrexia. As far as fetus is concerned, FGR, preterm, postterm, breech, oligohydramnios. And in intrapartum, if you have induced the labor with prostaglandins, or if you have augmented the labor with oxytocin, or if there was meconium stained liquor or bleeding in labor, or if you have given regional anesthesia. These are all the indications for high risk fetal hypoxia and acidosis, and indication for electronic fetal monitoring continuous. So it is also in patients monitored previously with intermittent auscultation, but you found that FHR is more than 160 or less than 110, or you found some deceleration, especially the early decelerations, or if you think that intrapartum risk factors have suddenly developed, you switch over to intrapartum EFM. Now, next part of my talk is basically what is this intrapartum electronic fetal monitoring. There are actually 3 things you have to understand. Number 1 is the terminologies. Number 2, how to interpret. And number 3, how to manage. So I will divide my next talk into 3 parts. So first, let us understand what are the terminologies in electronic fetal monitoring. First, you talk about baseline rate. I will explain each one of them a little later. First, let us see what are the terminologies. Next, beat-to-beat variability. Third, accelerations. Fourth is deceleration. In that, we have early deceleration, variable deceleration, and late deceleration. And finally, changes or trends over time. Just one odd deceleration is not that significant maybe, but if there's a trend of deceleration, continuous or successive deceleration, that is what we have to look for, and that is dangerous. Let me go now to baseline heart rate. All of us know from undergraduate level itself what is normal fetal heart rate. Fetal heart rate is, of course, 110 to 160. But then, if it is not a horizontal plain line it means always death, isn't it? So it's an irregular horizontal line. Sometimes it is 130, sometimes it is 140, sometimes it is 135, sometimes it is 145. It keeps dancing. This is because of the change of oxygen and carbon dioxide, and chemoreceptors will detect them and base heart rate. But what you have to see is that whether this variation is within the normal limit. And what is the normal limit? 110 to 160, right? So irregular horizontal line is a series of closely spaced points, each representing an individual heart rate calculated by the interval between two R waves in the fetal ECG. It is something like that. As I said, from one beat to another beat, if you really calculate the time and the speed, see at different intervals, there are different speeds, 138, 139, 138, 137. So it is not same all the time, but overall, it is in the normal range. So as I said many times already, normal is 110 to 160. Tachycardia means more than 160, but not just a flash. That 160 should last for more than 10 minutes. Similarly, it is maybe due to maternal pyrexia, initial stages of subacute fetal hypoxemia, or administration of beta agonistic drugs, or fetal arrhythmia, which is SVT or atrial flutter. So whenever there's tachycardia, you have to think of these things: reload maternal pyrexia or reload hypoxemia, administration of beta agonistic drugs, or fetal arrhythmias. Bradycardia means less than 110. Again, it should be lasting for 10 minutes, not just 1 or 2 minutes. And the reasons for bradycardia: normal fetus in post-dated pregnancies, or maternal hypothermia, administration of beta blockers. Above you saw beta agonist, here you are seeing beta blockers, right? Or if there's a fetal atrioventricular block, then also there can be bradycardia. The next terminology is variability. This is very, 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 very important. Now, variability is nothing but fluctuations in the baseline itself that are irregular in amplitude and frequency. For example, as you can see here, it's almost a straight line. That is called absent variability. Here you can see there is minimal variability, which is less than 5 beats per minute. Whereas this one is moderate, which is between 5 to 25 beats per minute. And here you can see this marked variability, more than 25 beats per minute. Variability factors influencing normal 5 to 25, 98% non-acidotic people. So if there's a good variability, which is between 5 to 25, you can be rest assured that this baby is fine. There cannot be any acidosis. Whereas if there's a decreased variability, which is less than 5 beats per minute, and it should be lasting for more than 50 minutes. In fact, it's unfair to wait for such a long time. This definitely suggests fetal metabolic acidosis, CNS depressants, fetal sleep cycle maybe, or pre-existing neurologic abnormality. So post-acidotic neurological damage is one thing, or pre-existing neurologic abnormalities another. Whatever it is, it can be seen as a decreased beat-to-beat variability. Now, increased beat-to-beat variability, it is also called saltatory pattern, is seen in some areas, but it is incompletely understood, maybe linked with recurrent decelerations when hypoxia evolves rapidly. The third terminology is accelerations. After baseline and variability, we have to think of accelerations. Now, there's an abrupt increase in the FHR from the baseline, and this is seen usually after 32 weeks. And if it is 15 beats per minute lasting for 15 seconds, we call it a reactive NST, which is a good sign. That means our autonomic system is very good and there's good oxygenation and all autonomic nervous system is playing beautifully. But this may not be seen before 32 weeks, or it may be seen, but the acceleration is not more than 10 beats per minute lasting for more than 10 seconds. That's exactly why we may not do NST before 32 weeks or even 30 weeks. We start doing it only after 30 weeks. But however, as far as the labor is concerned, we do not give much importance for acceleration. We give importance for deceleration. So, absence of acceleration in an otherwise normal intrapartum CTG is of uncertain significance and unlikely to indicate hypoxia. That's exactly why I told it is of not much of significance. What is significant is this terminology, the fourth one, decelerations. Now, what is deceleration? We have already told you it is less than 110, lasting for at least more than 10 minutes. Transient slowing of fetal heart rate below the baseline level, that is more than 15 beats per minute and lasting for 15 seconds or more. Now, there are two confusing things. When we say bradycardia, it is less than 110. But deceleration can be within normal limit, but it has dipped by 15 beats per minute. This is the difference between a careful doctor and a careless doctor. A careless doctor will wait till the heart rate to go down below 110. Whereas a careful doctor who is closely observing, yes, the heart rate has not gone below 110, but there is deceleration. What do you mean by that? Let us say the normal heart rate was 150, 150, but it has dipped to 135. That means less than 15 beats per minute. Now, if you just see 135 looks normal, because normal is 110 to 160. But what you must understand, the baby which was having 150, if it is losing 15 beats per minute, which is lasting for more than 15 seconds, means there is some developing hypoxia. I hope you understood. This is what we mean by a careful observation. I hope it is clear. The types of deceleration are early deceleration, variable deceleration, and late deceleration. Obviously, late deceleration is very bad. I will explain each one of them beautifully and graphically. Early deceleration is asymmetrical with the nadir coinciding with the peak of the contraction. That means it starts with the contraction. The nadir, that means the lowest point of the deceleration, beautifully coincides with the highest point of the contraction. As the contractions disappear, fetal distress also disappears. I hope it is clear. This is called early deceleration. Okay? The nadir, this is the nadir, that's the lowest point of the deceleration, coincides with the highest point of contraction, and this is called early deceleration. There is synchronicity with the contraction. It's like a mirror image. When I do a graphic like this, you will understand better. This is the peak of the contraction, right? This is contraction. This is the lowest point of or nadir of the deceleration. Now they are coinciding. It's like a mirror image, right? What is it due to? It is due to head compression. Now, how do you prove that? You change the position of the patient a little bit to the left lateral position from maybe she's lying on the back, which should not be the case. But anyway, you change the position or you just give Trendelenburg, then the head comes up. Head is not compressing on the placenta anymore. Then you know that it was due to head compression and it will be not a serious issue unless it repeats itself many times. Now, what is variable deceleration? Now, variable deceleration, it is variable in appearance and timing. There's no rhythm or rhyme. It does it whenever it feels like. As you can see here, it is neither coinciding with the peak of contraction, nor the nadir is coinciding with the peak of contraction. It is coming somewhere and erratically. Here it is not so deep. Here it is deep. Here it is shallow for some time, right? So that's what I mean. If I have to show graphically, see here, it is not coinciding with the contraction at all, and it is very deep. Whereas here, it is almost trying to coincide with the contraction, but it is not very deep. It's shallow. This is called variable deceleration. You see, it doesn't coincide at all, right? And blue line suggests that it is sometimes deep, sometimes not so deep. Baroreceptor mediated response to increased arterial pressure is the cause of this, and it reflects umbilical cord compression. So again, by change of the position, it will go away. What is called shouldering in variable deceleration? Acceleration before and after deceleration. As you can see, there is an acceleration, and after the deceleration, there is one more acceleration. So it's like raising the shoulder like that. Okay, so that is called shouldering. As you can see here, there is a peak here. This is one shoulder, this is another shoulder. Between them, there is a deceleration. Again, they are not coinciding with contraction anyway. U vein, that is umbilical vein, is occluded first, causing acceleration. Umbilical artery is occluded next, causing subsequent and rapid deceleration. Now, shouldering in variable deceleration, their presence indicates that the fetus is not yet hypoxic and it is still trying to adapt to the reduced blood flow, which means it is good. If you see shouldering, it is good, right? Their absence, of course, is worrying, as it suggests that the fetus is becoming hypoxic and it is not trying to adjust itself. Now, variable deceleration resolves if mother changes the position, which I have already told you. Now I come to all important late deceleration. Now, late deceleration, as you can see here, it starts somewhere after the contraction starts, not with the contraction. And the nadir, that is the lowest point of the contraction, is after the peak of the contraction. And when the contraction disappears, deceleration doesn't disappear. It will continue for some more time. So the onset, nadir, and recovery of deceleration occur after the beginning of peak and ending of the contraction respectively. So as you can see here, I will show in the graphic, which you can easily make out. This is the contraction. It starts somewhere, and the nadir, this is the nadir, is after the peak, and the contraction is over here, but the deceleration is not over here. It is over here somewhere there. As you can see, the red line is trying to coincide them. This is the nadir. The contraction is over, but this is not yet over. So prolonged deceleration means a deceleration that lasts for more than 2 minutes, but less than 10 minutes, right? And that is the one. A pathological one is more than 3 minutes, right? So this is more than 3 minutes. That is the thing which I'm trying to show. It is indicative of acute fetal hypoxia. From this point, no more waiting. You have to take her up for cesarean section. If the deceleration lasts for 3 minutes, that's it. You take her out. Then there is last one called sinusoidal deceleration. It's like a beautiful rangoli. It's a smooth sine wave-like pattern in FHR baseline with a frequency of 3 to 5 minutes persisting for more than 30 minutes. And this is of no use. This suggests fetal anemia in case of maybe RH isoimmunization, fetal maternal hemorrhage, twin anemia polycythemia syndrome, or severe hypoxia. Now I come to the last part of my talk, that is how do you interpret. This is by IPFM FIGO 2015. Based on the same three things what I told you, basal heart rate, variability, deceleration. Where did the acceleration disappear? I told you acceleration is not important. So FIGO has removed acceleration, okay? Only three things are taken. Now, what is normal? I have already explained, 110 to 160. And variability is concerned, 5 to 25 beats per minute. And deceleration is concerned, there can be 1 or 2 deceleration, but it is non-repetitive. What is pathological? If fetal heart rate is less than 100 per beat, I am talking about basal, right? And as far as variability is concerned, there is decreased variability for more than 15 minutes or increased for more than 30 minutes or sinusoidal pattern for 30 minutes. All are bad. As far as deceleration is concerned, there should be a repetitive deceleration for more than 30 minutes or one single prolonged deceleration for 5 minutes. FIGO says 5 minutes, but NICE guidelines says 3 minutes is worse. Now we have in between what is called suspicious, where abnormality is in any of the three, but not severe enough to be pathological. So they are very smart. They are not defining anything. It is neither normal nor pathological, comes under suspicious. What are you supposed to do? The interpretation is, when it is normal, there is no hypoxia. And when it is suspicious, probability of hypoxia is there. Whereas when it is pathological, there is high probability of hypoxia. What you are supposed to do? It's not a big guess. It's not a big brainer. It's no brainer. If it is normal, no intervention. If it is suspicious, rule out correctable causes. Maybe you can give some oxygen. Maybe you can change the position. Maybe you can give IV fluids. But if it doesn't improve, don't wait. You go for urgent action, expedite delivery. If it is second stage, instrumental delivery. If it is first stage, cesarean section. The same thing is put it in a different way by NICE guidelines. That is 2017. Same 3 parameters, basal heart rate, variability, and deceleration. But here they don't call it normal. They have to be different. So they call it reassuring. But the values are same, 110 to 160. Normal 5 to 25. No deceleration or early variable deceleration, but they are less than 90 minutes. They are calling a non-reassuring variety where the heart rate is between 100 to 110 or 160 to 180, and the variability is less than 5 for more than 30 to 50 minutes, and deceleration is lasting more than 30 minutes. Whereas abnormal, instead of calling it pathological, they call it abnormal, where the heart rate is baseline is less than 100 or more than 180, and variability is almost the same. But here you look at it, I told you, NICE guidelines says 3 minutes, FIGO says 5 minutes. But I think I will go with NICE guidelines. I don't want to wait for 5 minutes with the baby in deceleration. Now, how do you classify that? Normal means it suggests low risk for fetal acidosis. What is normal? All 3 features, baseline, variability, and deceleration, they are reassuring. Suspicious means 1 non-reassuring feature and 2 normal or reassuring features. 1 non-reassuring, 2 normal or reassuring. Pathological means 1 abnormal, which is pathological, or 2 non-reassuring features. So what you should do if CTG indicates need for urgent intervention, that means bradycardia or a single prolonged deceleration of more than 3 minutes, the baseline is below 100 beats, you take her for cesarean section. I will end my talk with 2 slides, which are very important from it is guidelines in Green Top guidelines, which is followed in the UK. Abnormal CCT action to be taken. Look for mother. What is mothers? M for meconium, O for oxytocin, T for temperature or toxemia, H for hyperstimulation or hemorrhage, E for epidural, R for rate of progress or CPD, and S for scar. This is RCOG. I have developed an acronym, Mother. Who is mother? Our soil is mother, is a Mother Earth, we say. I have created an acronym called SOIL, which means action to be taken. S for any guesses? Stop oxytocin. O for give oxygen. I for IV fluid. L for left lateral position. This is my prescription for mothers. Mother and soil are same. The last slide of the talk is the abnormal CTG 3-6-9-12 rule. What is this 3-6-9-12 rule? 0 to 3 minutes call for help. Think of delivery. 3 to 6 minutes perform soil. What is soil? stop oxytocin, give oxygen and IV fluids and left lateral position, shift the patient to OT. At 9 minutes, if the deceleration persists, one last chance for vaginal delivery to prevent a cesarean section, category 1 cesarean section. Try instrument. It could be forceps or vacuum, not one after another. No sequential instrument. But 12 minutes, don't wait anymore, do cesarean section. This is our COG guideline. Thank you so much for your patient listening.
Thank you very much.
Congratulations.
Thank you.
Okay.
Very well
Yeah, Radhika.
presented. And we'll request Meenu ma'am and we'll request Madhu ma'am to please, Aarti ma'am to please give their expert opinions after this and closing remarks.
Congratulations, Dr. Muralidhar V. Pai. You have presented your this thing interpartum fetal monitoring in such an excellent way. Each step was given, and I really appreciate taking this topic instead of fetal surveillance, because when we are doing the interpartum fetal surveillance, we are at this stage, the mother, fetus, as well as the obstetrician is at the crucial stage. So thank you for taking this topic. And again, congratulations, Dr. Pai, for telling everything, each and everything in such a simple way. It was looking like that we are sitting in the medical college lecture theater. So, and you have already given such a nice guideline for early deceleration.
That's the side effect of being a teacher in medical college.
It's such a lovely thing. I think everyone who is listening or talking must have understood. And this is such an important topic for each and every obstetricians. And I have many times I have heard your webinar, and whenever we have problem, we just go through your webinar. It is on the YouTube. So yes, everyone, it is a guideline.
Thank you.
So thank you, sir. Thank you very much.
Thank
You have beautifully given the guidelines for IPFM guideline, FIGO guideline, and NICE guideline, when to take action, 3 minutes, 5 minutes. These are the excellent things. I think everyone must have understood, and I don't think there is any question I have now for intrapartum fetal surveillance. Thank you, sir.
Thank you so much.
Thank you. Thank you, Dr. Muralidhar, for this excellent presentation. I will say the first slide was very important, and it had, I will say, it had the accumulation of many chapters in the first slide, which said that inappropriate use of oxytocin, failure to recognize fetal distress, inappropriate or failure to use properly the instruments in the delivery, timely cesarean section, and in the last, if we are not doing proper neonatal resuscitation. So this first slide was very important, and we should all, it was of utmost clinical importance for all of us. If we understand this first slide, then definitely. And later on, IPFM classification, FIGO 2015 and NICE 2017 classification, they were all mesmerizing talks, sir. And we all are enlightened by your expert opinions and knowledge. Thank you so much.
Thank you so much.
Madhu ma'am, can we have your remarks? Ma'am, you're muted, sorry. Madhu ma'am, you're muted. Saiti, can you help? Thank you, ma'am.
Thank you, Dr. Pai, for this elaborate presentation. I'm now feeling as excited as a first-year student of PG who is getting everything so clear now. And I think my take-home message for this will be like, we cannot give away with the intermittent auscultation for low-risk pregnancies.
Yes.
Especially for our PG students or in a very hectic labor room.
Yes.
And the second, the EFM, what you have told about this 3, 6, 9, 12 is something which everyone can follow in a format which can be passed on to even nursing staffs and the PG students. So I think I mean, excellent talk and so much to take home.
Thank you
Thank
so
you,
much.
sir.
Thank you so much. Thank Dr. Sneha again for giving me opportunity to travel all over the country. Last time I was traveling to so many places in North India. Today I'm in Uttarakhand.
Odisha and then North India, yes. Thank you so much, sir.
Thank you so much.
For sparing your time and of course your wisdom. Thank you so much, sir.
My
Thank
pleasure.
you. It's a great learning for all of us. Thank you.
Thank you very much. Pai sir. Very, very engaging, very descriptive lecture, and we're all in awe. Thank you so much. Thank you. And thank you to our respected chairpersons for a very patient hearing and for chairing the session. We move ahead to the last part of our academic session, a very gripping panel discussion, and I'm sure it's going to be a very, very enriching experience with none other than our very dynamic Sneha ma'am. Sneha ma'am, you need no introduction, yet you have so many accolades
Yeah,
to your
please go ahead. Please,
CV.
with this, we can go ahead. Thank you.
And we have two very senior, very seasoned, very, very, motivating seniors who are chairpersons for your session. Dr. Sarveshwari Nautiyal ma'am, the ever smiling and, always energetic and ready for anything we ask her. Sarveshwari ma'am, thank you very much for always saying yes and never saying no for anything. Thank you so much.
I know that's what Sarveshwari is all about. Thank you.
And our very dear Surbhi ma'am, who is always there for us. And I have always asked ma'am to be a part of various programs, and she has also never said no. Two very senior experienced members with us. Thank you so much for
Welcome,
being with
madam.
us today.
Welcome.
And we have a squad of very bright and brilliant young gynacs today in this panel for hyperglycemia and pregnancy. I'll quickly give an introduction for everybody. Dr. Vibha Mehrotra, she is the secretary for Kashipur Obs and Gynae Society. Dr. Manpreet Batla, a very dear friend from Batla Hospital, consultant OBGY. Dr. Raj Lakshmi Mundra, again a very dear friend from AIMS Rishikesh, the additional professor OBGY. Dr. Pallavi Pant Purohit from Haldwani, the treasurer over there and the assistant professor for GMC Medical College. Dr. Anushri Rawalpal, a very dear senior, past secretary for the Haldwani Obs and Gynae Society. Dr. Richi Solanki, ma'am, consultant at the KVR Hospital. Dr. Aishna Singh Sharma, joint secretary for our Dehradun chapter, a very dear junior. Dr. Sonam Jain, ma'am, a very dear senior from Kashipur OBGY Society, and always smiling, always encouraging. Dr. Aanchal Agarwal, ma'am, again a very, very dear senior from Himalayan Institute of Medical Sciences. She's an assistant professor. All of them are very bright, brilliant, and the young brigade that we have. And we welcome all of you for this wonderful panel.
Yes. So a very good evening to all of you, friends. And I once again welcome all my respected experts as well as the panelists. So without wasting any time, I would say we straightway go ahead with our panel discussion. So friends, diabetes, I'm sure people, worldwide, India is recognized as the capital for diabetes, and that is not a matter of pride for all of us. Just see the evidence, whether it is type 1, type 2, or gestational diabetes. About 60 million women of reproductive age group worldwide, they have diabetes mellitus, and this will double by 2030. That is what the evidence says. At least 40% of these diabetic pregnancies, they are unplanned. And why are we worried so much about this? So I would just take a moment to, stop this, because I think this is a different PPT I have opened. I'll just beg your pardon, and for a moment.
Hi, in the meantime, I'm so sorry. I'm Dr. Anupama. Couldn't log in because
yes,
of
please,
other.
Dr. Anupama, welcome. We are very happy to have you. And in fact, we were missing you. We thanked you at the beginning only. And I thank you once again. Thank you for being the,
Sneha, I am glad that you made it happen. Yeah. So, thank you so much. And I would also want to thank Dr. P.K. Shah and Dr. Pai, who had been doing the wonderful, I heard in between the beautiful session which was going on. And Radhika, thank you so much.
Thank you for joining in, ma'am, and for all your efforts for backing us up.
And Shweta ne join kiya tha? Dr.
Yes,
Shweta
ma'am.
Yeah,
She's down with a little cold and cough, so I think the video is off, but ma'am is with us.
Okay, chal. That was great. Namaste Sarveshri ma'am. Ma'am, carry on ma'am. बीच में time break था, इसीलिए मैंने interrupt किया.
Thank you, my dear. Thank you. I'll just because there was some little editings which I have added.
सारे सेशंस मैम बहुत प्रैक्टिकल से हो रहे हैं. मैं देख रही थी IGR वाला भी, और वो डॉक्टर पई का तो इलेक्ट्रॉनिक फीटल मॉनिटरिंग की छोटी-छोटी चीजें थी, कुछ जैसे एक्सेलरेटेड, वो सब हम मुझे लग रहा था नया कुछ आ गया है, बिकॉज वी वर नॉट नोइंग क्वाइट अ फ्यू ऑफ देम. क्या ये इंक्रीज्ड एक्सेलरेशन जैसी चीज पहले होती थी, या ये कुछ नया ऐड हुआ है अभी?
मैम पहले
मेरे
सिर्फ एक्सेलरेशन का था, इंक्रीज
हाँ, इंक्रीज्ड एक्सेलरेशन जैसी चीज मुझे तो आज मेरे को लगा कि मैंने पहली बार रजिस्टर करी।
Ma'am,
हाँ
even the shouldering one was very nice, है ना?
Yes, shouldering
हाँ
acceleration, yes.
या अब हाइपरग्लाइसीमिया भी बहुत ही प्रैक्टिकल
Ma'am, we will need
इम्पोर्टेंट
your
चीज है।
tips and this thing also, questions also.
हाँ हाँ
Very
हाँ
practical
क्वेश्चन
questions you ask, जो हम शर्मा जाते हैं, आप पूछ लेते हैं.
Knowledgeable Anupam ma'am has joined at the perfect time, ma'am.
Sorry for the technical glitch. I just because there are so many presentations, so I think I just thought maybe the best one yeah. So the most updated.
उत्तराखंड वालों के लिए बेस्ट ही निकालेंगे स्नेहा मैम।
Yes, yes, yes. I have it. Don't worry. It was little. I will just, yeah. I got the presentation which I have updated yesterday only. So this is for you. Yeah, I hope you can see now, all of you.
Yes, ma'am.
Yeah, so I have already welcomed all of you. So friends, I make it very, very simple and practical. No hi-fi things, no theoretical guidelines, etc., etc. Okay, so all of you know what is hyperglycemia. It is carbohydrate intolerance of variable degrees that happens or is recognized for the first time during pregnancy. As I have already said, that it is not a matter of pride for all of us to have, highest incidence of diabetes mellitus or hyperglycemia during pregnancy. You can see the incidence of hyperglycemia, one baby out of those 6 born, they occur to, women who are having some form of hyperglycemia. 84% of these women, they have gestational diabetes. So that means gestational diabetes, the incidence is very high, though diabetes in general, the population is growing. And as I have said, it is almost 40% of these diabetic pregnancies, they are unplanned. This is what is the statistic worldwide. We don't want to go to this, but I would just go ahead with, to Dr. Vibha Mehta. What is the impact? Are we really worried about this hyperglycemia in pregnancy? Why are we worried about the hyperglycemia in pregnancy? And what is the impact of hyperglycemia on the perinatal outcome as well as maternal outcome? So, Dr. Vibha.
Unfortunately, ma'am's had a emergency case, so I'll take it up if you don't mind.
Yeah, of course.
There can be a short-term impact, there can be a long-term impact. On the short-term impact, you may have at the...
Radhika, just a moment. I would interrupt you here. I would just ask you the second question first. Why
Yes,
are you worried so much about hyperglycemia? I mean, why?
Because it can have long-term sequels also, ma'am, to it. We can have, non-communicable diseases which we can, contract because of having hyperglycemia in pregnancy.
Right.
Like diabetes, obesity, and hypertension. So even the delayed sequelae, long-term sequelae are also a matter of concern for us.
Right. And is there any correlation between the sugar levels of the mother with the perinatal mortality?
Ma'am, definitely we have a correlation between the sugar levels and the mortality. So we've divided the range as you're showing us that more than 200, there is about 35% of chances of perinatal mortality. And between 150 to 200, 16%, and so on, 8 and 4%, ma'am.
Yeah.
But there is a correlation, so that's why we worry.
Yeah, so friends, look at the difference in the perinatal mortality. But the moment the sugar goes above 150, the mortality becomes 16%. And if it goes above 200, it becomes 35%, so high. So these figures bring out the stark necessity for blood sugar level control for these women. So it's not only about only medication, but the nutritional counseling and, the euglycemia that should be achieved before planning. As I've already said that almost, one baby is born to the woman out of 6, one baby is born to the woman having hyperglycemia. So, and these 40% of these pregnancies are unplanned. That's a very high incidence. And this year, if you remember, the theme for Foxy is, pregnancy should be a choice, not an accident. It should be a planned pregnancy. So friends, always make your lady euglycemic. Stabilize her glucose if at all she is diabetic. If she develops GDM, at the very first visit, you have to diagnose it. So the pre-meal, the sugar level should be 69 to 90 before breakfast, and before lunch, lunch and dinner, it should be 60 to 105. At no point of time they should go above 120 milligram percent. So you were talking about the long-term and short-term impact, Dr. Radhika. I would ask the next panelist, Dr. Isha, and other people. You can take this discussion ahead. So, Dr. Manpreet.
Yes, ma'am.
Yeah. So, what are the effects on the fetus and the mother?
Ma'am, short-term effects can be on the mother. There are more chances of maternal morbidity, then there are chances of hypertension. Big baby, macrosomial baby can lead to PPH in mother, hemorrhage, and obstructed labor, and later infection. And if we land up into an emergency cesarean, then there are more chances of delayed wound healing in diabetic patients.
Okay, you're right. Anybody else wants to add anything right from early pregnancy? Yes, Dr. Raj Lakshmi. Yes, Raj Lakshmi, Anushri, anybody. I want to see all of you. Please unmute and open your video.
Sugar levels are Good evening, ma'am. I'm Dr. Sonam. Ma'am, if the sugar levels are very high, then there are such chances that the fetus, like we have early death also, early embryonic death also is very common if HbA1c value is very high from the starting itself.
You're
And
right.
then we
Please go ahead.
Yes, ma'am. And if the sugar levels are not controlled, then these babies are more prone for having any cardiac anomalies.
Right. So as you can see here, see right from early pregnancy, as you know, Radhika said that, you have short-term impact and you have long-term impact. Also, you have, problems with the mother and problems with the fetus as well. So right from early pregnancy, if you look at this, then there can be spontaneous abortion, even congenital malformation. There can be growth issues, either very large baby macrosomic or even the fetal growth restriction. If at all everything goes on well and the baby is macrosomic, maybe there is a chance for shoulder dystocia, birth trauma, fetal distress, and also neonatal hypoglycemia, hypocalcemia, and the hyaline membrane disease, as we used to call it, as respiratory distress syndrome, hypothermia, polycythemia, long-term obesity, and diabetes mellitus also, right? And for the mother, what is the effect on the mother? What is the effect on the mother? All of you, Dr. Pallavi,
As already said,
name yourself. I request you to name yourself. Maybe I can recognize you.
I'm Dr. Pallavi Pancharovit. I'm a assistant professor in Halwani Government Medical College and also.
Yes. Go ahead, please.
Ma'am, in case of risk to the mother, there are several risks starting, like at the end, there could be, because of fetal macrosomia, there would be more risk during delivery. There would be shoulder dystocia leading to injury to the maternal perineum. And also the hyperglycemia would predispose mother later on in, it could lead to type 2 diabetes mellitus. It was probably only unmasked during this.
Right. So if you talk about only diabetes mellitus, the per se the patient can have the complications because of diabetes per se, that can be vasculopathy, retinopathy, and nephropathy, correct? And if you take this lady right from early pregnancy, you may have the chances for development of preeclampsia, right? Diabetes also has it has got an association. If you go for the maternal characteristic and score this lady, she goes into high risk. Okay, so score 3 for her. So she is very much prone for preeclampsia, eclampsia, and then when you go ahead, definitely there is a problem with vasculopathy, retinopathy, nephropathy, as I have already told you, and then during labor, as you said, maybe labor dysfunctions, traumatic delivery, or maybe operative interventions, instrumental or cesarean section, postpartum hemorrhage, sepsis, and even later on, as you rightly said, type 2 diabetes and long-term obesity, or even the metabolic syndrome, right? So everything is possible for this, and that is why you have to take care of this pregnancy very well. So now we go ahead with Dr. Manpreet. You have, I'm taking single aspect for short cases, okay? So Mrs. C is a 22-year-old prima gravida, and she comes to you for first antenatal checkup. She's just 10 weeks. When you examine her, you find she's 152 centimeter tall, weighs 69 kg. Her BMI is 30, that is high. She does not have a family history of diabetes. Will you screen her for diabetes? And what screening is to be tested? Dr. Manpreet.
Yeah. Hi, good evening, ma'am. Yes,
Hello.
definitely. I would
Yes.
I would screen her because seeing the BMI is too high. The normal range of BMI is between 18 to 25. So 30 being on a higher side, definitely whenever it's her first visit, I will begin screening at that time only.
Okay, so you will screen, but you're saying that you will screen because her BMI is high. Okay.
BMI is,
Any
yes.
other difference of opinion?
I would like to say, ma'am, we will do a universal screening of all the patients because
Perfect.
India falls in an endemic zone for diabetes, and even though there are
Right.
different study groups which tell about different things, but now it is recommended, as far as I
Right.
have read, that we should do universal screening, and at the first antenatal visit, the patient should be screened.
Right. So, Dr. Manpreet, you are partly correct because there was a time 3 decades ago when when we were the PG students, maybe 35 years ago, we used to have only high risk screening. Age above 35, obesity, family history of diabetes, and PCOS. These were the 4 risk factors. They only we used to screen. And people used to think that, the placental hormones, they act only after 5 months, that is second trimester. But that is not true. And so the concept of universal screening came, whereby all the organizations, including FOXY, FIGO, NHM, DIPSI, everybody unanimously agrees to the universal screening. That is, every woman during every pregnancy. That is, if the first pregnancy she didn't have GDM, that doesn't mean that you shouldn't screen her for second pregnancy. Every woman during every pregnancy. Very clear? Now you tell me, how do you screen, whether you do random sugar, fasting, post meal, 50 grams, 75? Yes. Manpreet, we can continue with you.
Ma'am, we
Yes.
begin the random testing. If the random testing is high, we'll go for a GCT for 50 gram glucose.
Okay. Anybody else wants to?
We will do the 75 gram OGTT as the screening test at the first booking visit itself, as per the NHM guidelines also.
Perfect. So basically, you will do the screening twice during the antenatal
First
visit.
visit.
Twice. Yes.
Yes.
First visit in 24 to 28.
Yes. First visit first screening at the very first point of contact, that is first visit, antenatal visit, and second between 24 to 28 weeks. And if at all this lady, has still a high risk, you feel that she's still high risk, then again 32 to 36 weeks. Okay. So now Dr. Rajalakshmi. Dr. Rajalakshmi. Do we have Dr. Rajalakshmi?
I think she did join.
Yes, ma'am, I'm there.
Yeah,
Yes.
yes, ma'am.
Please. So that's the reason I'm requesting.
Ma'am, I'm there.
Please rename yourself. So
Ma'am, we want to see your beautiful face, Rajalakshmi ma'am. You can't hide.
Saiti, can you please rename?
I'll coordinate Saiti
My
ma'am.
video is on.
Please do. So how to do the
Ma'am,
test?
I'm Dr. Rajalakshmi.
Hello.
Ma'am, as we have already discussed, we are doing universal screening. So we will be taking 75 gram oral glucose tolerance test. We will be doing that.
Okay.
And for that, we give, irrespective of the last, ma'am, irrespective of the last meal, we should give 75 gram glucose mixed in 300 ml of water.
Perfect.
The lady will consume it in 5 to 10 minutes.
Yes, 5 minutes. Yes.
5 to 10 minutes she will take it, and suppose she has some kind of vomiting within 30 minutes, then we will repeat the test next day. But if there is no vomiting, then we continue with the test. Now,
or if she has vomiting after half an hour.
Ma'am,
Then
after
also
half an
you
hour, we don't consider. Ma'am, generally after half an hour, we can continue with the test.
Yes,
ma'am.
Perfect. That is what message we have to give, because she's first trimester. So she will be vomiting. So if she vomits before 30 weeks, you're right. Before 30 minutes, you have to cancel some other time. If she vomits after 30 minutes, you continue with the test. Perfect.
Yes,
go ahead.
So after that, 2 hours later, we will take blood sample for the patient. And if the values are more than equal to 140 milligram per deciliter, then we label her as gestational diabetes mellitus.
But
Yes.
suppose the value is
Right.
less than
And
140, then we consider.
how to interpret that?
Yes, ma'am. If it is more than 140, we level her as GDM.
Okay. So we asked Dr. Pallavi.
Yes, ma'am. Ma'am,
Yes, screen pause.
The government of India and the DIPSI guidelines endorse modified OGTT, which is 75 gram of glucose irrespective of the fasting status, and 140 is taken as the cutoff. It is more than 140, then it is considered as GDM. If it is between 120 to 139, we consider it as gestational glucose intolerance. But what WHO, ADA, and IADPSC suggests that the person should come 8 hours fasting, and the first eating is taken in fasting state. And
We
the
don't go
fasting.
into all those confusions. We give a very clear-cut message to our audience. Okay, Dr. Pallavi. We just stick to at present the DIPSI, because our audience, or maybe our obstetricians, are still lots of confusions they have, so many guidelines. So we stick to DIPSI only. Okay.
Yes.
And we know that our women don't come very frequently. The moment they have come to you, whether she is full stomach, whether she is empty stomach, whether she has had her last meal, irrespective of the timing of the last meal, we should go ahead with the testing, right? Okay, please continue.
Ma'am, so I just think that the IADPSG is more relevant in the state of overt diabetes when it is unmasked. So in those cases, then those risks like vasculopathy, retinopathy, and there are further higher risks like IUGR to the baby. So there it holds some significance.
Okay, agreed. So
I would just like to interrupt.
Yes, please go ahead.
Ma'am, I'm Dr. Sonam. I'd just like to interrupt in between just one small point.
Okay.
As Dr. Pallavi ma'am was saying. Ma'am, actually the requirement, I just want to say all those guidelines of ACOG and all, they did not had any Indian population study center. So that's why it was the need of DIPSI. DIPSI was done on the Indian population, and Asians are actually more prone for hyperglycemia. So that's why this test was actually followed, and we are following these guidelines.
Perfect. That is what the message is, that these are Indian guidelines and, done on the Indian population. We don't really match with our Western counterparts, and that is why we have to follow these guidelines. Okay. That is suitable for South Asian population. So we go ahead with the same now, another case scenario. Dr. Anushri. Hello, Dr. Anushri. Do we have Dr. Anushri? So we have this, yes. Dr. Anushri?
Yes, ma'am, I'm here. Sorry. Yes, ma'am.
Please name yourself. I'm really
Ma'am, we cannot name ourselves. The person who is in
Radhika,
charge,
can you
only they
please
can
do
name, I
the
think.
honor? Radhika?
Actually, you
I've
can,
been trying to name myself since 1 hour. I'm not able
मैं
to.
बता रही हूँ कि कैसे करना है रीनेम. आप अपने उस पे क्लिक करें. उसमें ना 3 डॉट्स आएंगे. उस 3 डॉट्स के ऊपर जब आप क्लिक करेंगे तो उसमें से एक रीनेम ऑप्शन आएगा. उस पर क्लिक करके then you can rename yourself. अभी मैम क्वेश्चन पूछ लें, उसके बाद everybody can do it.
Yes, perfect. Thank you, Anupama.
मेरा तो screen ही चला गया.
Mrs. C, she has her fasting glucose, she comes with a report of fasting sugar level, okay? The results are fasting sugar is 86, HbA1c is 5. Listen to the questions very carefully, because these are all practical cases, fasting blood sugar 86, HbA1c 5.6. My first question is, does she has diabetes, Dr. Anushri?
No, ma'am.
Okay. Does she have GDM?
No, ma'am.
How can you say that? Does she have a diabetes? No. Agreed. Perfect.
GDM, we have not. This is the value of the. This is the value of. We have not done the DIPSI. That's what you're saying.
Yes, perfect.
Yes.
Because the screening test is DIPSI only.
Yeah. True.
Screening for GDM is DIPSI.
Yeah.
Right?
Yes.
So in respect to the DIPSI, positive, negative. Okay.
Yes,
So does she have GDM?
Sure.
We are not sure. Does she needs to be tested again? Yes.
Yes.
And how? So when?
75.
Ma'am, as of now, we can do a 75 grams DIPSI. And then if it comes out to be negative, then we have to reassess her at 24 to 28 weeks. Because again, the physiology says that the altered glucose tolerance starts in the second trimester after 20 to 24 weeks. After 20 weeks.
That we don't believe. We have now.
Yeah, we have done the universal screening when she visits us first. If it comes out to be negative, then we do a check at 24 to 28 weeks.
So maybe that time, first time it was negative. Okay.
Yeah.
So Dr. Richi Solanki, we have Dr. Richi. So do we have Dr. Richi? Please say hi. No? Okay. So we have this, repeat testing at 26 weeks. And her results are 2 hours, 75 gram glucose. So obesity, 168 milligram%. Does she have GDM?
Yes.
Yes.
How will
Yes.
you manage her? How will you manage her? We don't have Dr. Richi. We can go ahead with the next panelist, Dr. Ishik Manpreet. Dr. Isha, you want
Good evening, ma'am.
Good
Good
evening.
evening, ma'am.
Yeah.
Yes, ma'am, she has GDM. So the next mode of treatment would be medical nutritional therapy. So we take her up on diet and exercise for 2 weeks. And then after 2 weeks, we do her 2-hour postprandial value to see whether it is less than 120 or more than 120.
Perfect.
And yes, ma'am. And
but then your patient will ask you, Madam, how do I go for medical nutrition therapy? So can you guide me on this?
yes, ma'am. So, ma'am, for diet and exercise, for diet, the carbohydrate, like if you take for Indian population, if we take a thali, half the thali should be non-starch carbohydrates and half the thali can be regular carbohydrates.
Okay.
And when it comes to exercise, you start it with at least 20 minutes
no,
a day.
my dear, there is
Yes,
little
ma'am.
confusion from side. Half the thali is non-starchy vegetables that I
Yes,
agree.
ma'am.
And
Yes, ma'am.
half the thali is proteins and fats.
And fats. Sorry,
Okay.
ma'am. Yes, ma'am.
Little
Yes, ma'am.
confusion. Yeah. So
Yes,
I
ma'am.
will correct you. Okay.
Yes,
Now
ma'am.
we will discuss this MNT in depth for the next case.
Yes,
We go ahead with now Isna.
Yes, ma'am.
We continue with you. You have this primary gravida, 16 weeks pregnancy. Her parents are diabetic. She comes to you with a GCT report of obesity, 179 milligram%. Is she diabetic?
Yes, we label her as GDM, but because she has
My question is she diabetic? That means, is she over diabetic?
Ma'am, we will have to do other tests to confirm whether she's over diabetic. She's not over diabetic by the GCT value. If this value would have been more than 199, then we would have taken her as over diabetes.
Perfect. So that is a very important. If it is close to 200, she's over diabetic.
Yes,
But
ma'am.
then
Yes,
you
ma'am.
need to confirm by doing what investigation?
Ma'am, a baseline HbA1c and fasting and PP would be good because there's a strong family history of diabetes in her.
Yes, yes. So HbA1c, to know that whether last 3 months also she had, fluctuating or very high blood sugar levels. Okay. So Dr. Isna, suppose this lady you have, so how would you go ahead with this management? How much time you want to give her? What all things you suggest her? How should she go ahead with the
So right now, because she's at 16 weeks, so she's still in her second trimester. So we, like I mentioned earlier, we take her on diet and exercise. That is the medical nutritional therapy for 2 weeks. Then after 2 weeks, we do her postprandial 2-hour sugar value. If that value is less than 120, we can continue with diet and exercise itself. But in case that value is equal to or more than 120, then we have to start her on insulin and then monitor her
Now
sugars.
here I pause you once again.
Yes, ma'am.
Okay, I have purposefully put this, to take you away from deceive you. Insulin. Is it only insulin? What is your opinion? Should it be insulin only, or can it be metformin? If no,
Yes,
why?
ma'am.
Dr. Achal, I can ask you. I can see you very curious. Yeah.
Ma'am, metformin is a good alternative.
Yes.
It is still a little debatable as per the studies go, but metformin has been seen to be very effective, and it can, as an oral agent, the compliance is better, risk of hypoglycemia is less. Hence, the next logical step would be metformin. If it doesn't work, after 2 weeks of metformin, if it doesn't work, then we can switch over to insulin. That is what we
But then
really
what
do.
is the reason I have put this insulin here?
Ma'am, the problem with metformin is it crosses placenta, so it goes to the fetus. So the risk of that is why
Your
we prefer.
patient is 16 weeks, no? Your
Right,
patient
ma'am.
is 16 weeks, her organogenesis is complete.
Right, ma'am.
Start
Ma'am,
after 20 weeks.
ma'am, actually, we can go by the
All of
HbA1c.
you are correct. I just tell you that insulin is still the first line of
Drug of
treatment.
choice.
It is
Yes, ma'am.
still the first drug of choice by all the evidences. Okay, this is beyond doubt. But because our population is very poor, majority of our population stays in the village areas, people are uneducated, they do not have anybody to, they're not educated so much to understand the signs and symptoms of hypoglycemia. They cannot even test. So self-testing is also not possible. If at all they have such groups and who can test for them, they have good healthcare providers, we can always prefer insulin. But because our population is so poor and uneducated, we cannot take this risk. So something is better than nothing. So what these guidelines say that whenever, even if some of these guidelines, in the absence of the national resources, you have to follow this oral anti-diabetic or oral hypoglycemic agents, because for the population, it is something is better than nothing. Okay, otherwise, see, if you can't give insulin to such people, then do we just leave them like this? No. So metformin is equally effective and equally safe as well. So especially 16 weeks onwards, yes. So whenever you have a population who is uneducated, cannot test themselves, cannot follow the symptoms and signs, then definitely metformin is a good option. Okay. So
Can I interrupt,
yes,
Dr. Sneha,
please, please.
Ma'am, in such a patient, the exact case scenario in which the levels of a diabetic offspring daughter is 179, would you not start metformin along with medical nutrition therapy? I understand that it is not in the guidelines, but if she would have been my patient, so directly along with medical nutrition therapy, I would have started her on metformin and
Yes.
watched it for 2 weeks and then decided whether the insulin is to be started or not.
Yeah, actually, the reason behind this is, if at all you have a patient who is 179, it's not a over diabetes, right? But then you go ahead with medical nutrition therapy, and if you have a very good content, somebody has already talked about, I think Dr. Achal, that if it is after 2 weeks, if the postprandial is less than 120, then of course you don't need any anti-diabetic agent, because otherwise that times you will
179 is a quite high level. So maybe I would have gone it this way. I mean, I'm talking about day in, day out, which I am practicing.
Yeah, but then
I might be wrong in according to the
not
guidelines.
wrong. Not wrong exactly. You are not wrong. See, whatever evidence we have to always club with experience. So your experience and expertise also will work for this, definitely. But what usually the experience is, these are the women who are diabetic and obese, and they don't know what to eat and what not to eat. So if you give them proper guidelines, proper guidance to restrict their calories, restrict, and their spread also, that how they should restrict their carbohydrate intake, that too, we are coming to it now. So we directly go to medical nutrition therapy, that you have to decide how much calories and what spread is to be taken. So
perfect. I just wanted to make this point because my threshold for giving Bigomet is quite low, because in PCO patients, as it is obese PCO patients, which were preconceptually,
definitely yes, but our
we
patients,
give them,
if you see this, this lady, neither she is obese, the information is not provided that she is obese or she is PCOS. Okay, Dr. Anupama, actually you are right, but then see what message we want to give from this case is, even FIGO says that 90% of these women are, treated by MNT alone. Okay, that is what is the next message. If you see the slide, I will show you. 90%.
Go along. Yeah.
Okay.
I would want to read all the slides properly.
Yes,
Don't worry.
yes.
Yeah.
So we now slowly go with the discussion about the medical nutrition therapy. So I want anybody to extemper and go for this. Yes, Sonam, you want to take up this?
Yes, ma'am, I'll take this up. Ma'am, as already we have discussed, like medical nutrition therapy is the cornerstone in GDM. About 80 to 90% of the patients can be managed with the nutrition therapy. So for this, first is of all is important at the first appointment itself, we should have the patient consultation with the dietitian. And the patient should be advised 3 major and the 3 minor meals, as we advise in the normal pregnancy and diabetes. And that diet chart should be adjusted so that the patient should be knowing what to take and what not to take, because this calorie restriction will reduce the insulin resistance, and which is more important in reducing the blood sugars post meal than the pre meals raised values. If we
So
go according to
I would like to disturb you or
the
interrupt you here. First, we talk about the calories. How do you decide that how much calories she should take?
calories, we depend upon the pre-pregnancy BMI. If the patient is in the lean BMI, like less than 19, then we will
Right.
recommend a calorie intake of 35 kilocalorie per kg. If in the normal BMI 19 to 27, we will recommend up to 30 kilocalories. And for obese, ma'am, we
So
will
these
consider
charts
more
are there.
than
These charts are there. Not to worry. All of you can go through this. But the message is that she has to, her caloric requirement will be decided by her pre-pregnancy weight, how much weight gain she is allowed, and her level of activity. Okay, correct? That is
Yes,
what is the message. Now, why do we stress so much on the medical nutrition therapy? Can you please speak on this?
ma'am, because if the patient is taking complex carbohydrates, and if she is taking less amount of fats and saturated fats, her resistance to this insulin will also come down.
Yes.
Because pregnancy in itself is a hyperglycemic state.
Yeah, so
So
the
we have
medical
to reduce that.
nutrition therapy not only manages the blood sugar level, but also provides adequate and optimum nutrition to the mother as well as the fetus, and it also helps appropriate weight gain. Okay, so medical nutrition therapy, as you said, almost 80 to 90% of these women, they respond to medical nutrition therapy alone, and that is why the guidelines say that not to be in hurry of starting any hypoglycemic agent, whether oral or injectable. That is what the guidelines say. And that is why we give what we say, we give 2 weeks time to the patient to adjust herself. Okay. So that is what is the very essence of this message, that, if at all she goes for medical nutrition therapy, or if at all later on she requires insulin, the requirement will be less, her HbA1c level also comes down, and even the perinatal and maternal complications are less if you give the medical nutrition therapy. Now we come to the details of it. So anybody can take up how much percentage of carbohydrates, fats, what carbohydrates and what fats. Okay, please go ahead. We can start from Dr. Isna, and then we can go ahead with Dr. Anushri. Yes.
Yes, ma'am. Thank you. Ma'am, the total carbohydrate intake, like you mentioned, should be around 55 to 60%. And
that is for a non-diabetic or non-GDM patient, but for her, we reduce.
In this case, it should be up to 50% or less.
Right.
And fat should be around 25%, and protein should be again 25%. Again, the half thali thing that we had mentioned, that you had discussed, ma'am, before.
Right.
The same thing.
And
Yes.
even in the carbohydrates,
The complex carbohydrates are better. Yes, ma'am.
So how will
Yes.
you, so that is what is called as glycemic index. The
Yes, ma'am.
food, how do you calculate the glycemic index? The amount of sugar raised or elevated, and the level, or up to what time it is maintained. That decides the glycemic index. So fruits come in the medium glycemic index, and the cereals and wheat and all this they have high glycemic index, and the fibers, legumes, lentils, and nuts, all these come in the low glycemic index. Okay, so that is how you have to actually individualize the approach towards the patient, and these are the healthy fats. So what fats you have to allow her, what fats you should not? Tell me. Anybody can talk about this. I want you to go through.
Ma'am, saturated fats should not be allowed. Trans fatty acids, saturated fats should not be allowed.
Okay.
And healthy fats like omega-3 and
yes,
oils rich in PUFA N6 and all should be allowed. That is healthy.
Yes. So the simple message, see, this everything is given in the books and on the net also. What I'm going to just tell you, that green color, that is polyunsaturated and monounsaturated fats, they are good to consume. Green color is good to consume. PUFA is okay to consume, and red is absolutely no. Okay, they are bad fats. Now, suppose you have a South Indian lady who fills her plate like this. So how do you can't tell her 300 calories, 400 calories. How do you help her in choosing her spread? How to replace this?
Ma'am, we'll ask her to replace with more of green vegetables.
And
we will ask her to add more, like 3 small meals and three snack meals to be added in the meal.
So not at a time so much to eat, but in fact, thus one single meal she has to divide into 2, 3 and replace it with non-starchy vegetables and proteins. Okay. So any specific advice for exercise, Dr. Achal?
Exercise is strongly recommended, ma'am. For any normal pregnant patient, we
Mhm.
usually advise 30 minutes per day or 150 minutes per week. That is
Yes.
3 to 4 times per week, the patient has to exercise. But for GDM, especially, we have to increase it a bit. That is 30 to 45 minutes per day.
Right.
And she can start with 20 minutes per day, not so that not to overexert. And especially if she does that after meals, then it gives more result because it also reduces the glucose level, the glucose peaks after the meals.
Right.
And even if she cannot walk, she should sit on a chair and do
Yeah.
some arm exercises after her meals. 10
Yeah.
minutes per
Yes.
after every meal.
Right. I can see
And
Dr. Surabhi joining from her car. So, madam, can we have your expert comments for the discussion up till now?
Hello.
Yeah.
Hello.
Hello.
I think Survi is not there. And
No, she's there. She's there. She's there.
Hello. Hello.
Yes, yes. Please go ahead.
Okay. What to say about this panel? I think all the panelists are well versed with the subject and moderator is excellent.
एक तरफ
Okay?
तो मेरा
So
बोलने का टाइम
everything is covered. Acha, Survi, you are there. You can give your comments.
Tiger?
Yeah. Now I'd like to summarize. All the panelists are excellent. And I would like to read the FOXY recommendations. There should be universal screening for GDM. Is that right, Dr. Sneha?
Yes, my dear.
Particularly in the first trimester and again between 24 to 28 weeks.
Yes.
And a single step 75-gram OGTT with a 2-hour sugar of more than 140 milligram per DL is diagnostic.
Right.
And if you see an obese lady in your OPD and she is pregnant, then immediately your mind should go that she can be a GDM candidate at whatever phase of pregnancy, or she is coming for infertility. You should do the screening.
Yeah, but then as you said, yes, universal screening, that is a very good message from your side, every woman during every pregnancy. So thank you, Dr. Vibha and Dr. Sarveshwari. You,
But
madam.
I just want to say few words.
Yes, please.
We have not reached to the term. Have we reached to the term?
No, we are going ahead. Don't worry.
No. Okay. If the only thing I want to say is if you reach a term or the patient is going to deliver, what anesthesia will you like to give to your patient? Number one.
Yes. So,
And why? And why? So I say we can give combined spinal and epidural to the patient because they will decrease the stress response. Okay. And stress response, say, I mean catecholamines, adrenaline, noradrenaline, and cortisol. Okay. If we do give GA to the patient, these response will increase. So stress will increase, and stress increase will increase the level of glucose in the patient. So it's better to go for a normal delivery. It is better in tertiary center where the epidural analgesia is available And the patient can go for normal delivery with this epidural analgesia, which we did in our tertiary center. We had a very good anesthetist. The anesthetist can't leave the patient after giving the epidural. He has to stay there till the delivery. This was one thing. And today I have read in the Times of India that China wants more population. Why? Because the population of China is reducing, and they have arranged a tertiary center where they have arranged a epidural analgesia for the normal delivery. So this is what I just wanted to mention because we have not reached to the term.
Yes, yes. Thank you, madam. So we are trying to go ahead with all your permission.
Okay.
So I asked my panelists that whether for this patient, in addition to monitoring blood sugar level, how do you evaluate the mother and the fetus during first trimester, during second trimester, and during third trimester? So we can have one by one. All the panelists, please come on. Dr. Manpreet, please start.
First time we'll begin with the first trimester, and
Yes,
we'll go for 75 gram glucose testing, and we'll categorize her.
Good.
No, already now you have diagnosed her. She's GDM. You have given her 2 weeks time. You have given her medical nutrition therapy, and your patient is now well controlled on your medical nutrition therapy only. Okay. So now how do you evaluate?
Ma'am, we'll keep monitoring her. We'll monitor all her BP recordings because she can easily land up into hypertension, PIS. Then urine, we'll get the urine tested for proteinuria.
Yes.
And we, in certain cases, if she has certain issues regarding some nausea, or if she says there is a little blurring of vision, we can get her eye test, retina tested.
Okay. So, and go ahead with the fetal screening also.
Ma'am, we'll begin with the fetal screening. We'll get her.
I've prepared it for you. Please.
We'll get her NT-NB nuchal translucency tested in 9 to 11 weeks, and we'll get her dual markers test done.
Anything else? What about nuchal translucency? NT scan, is it different for a diabetic lady? Is the interpretation little different? NT scan usually we do for aneuploidy, right?
Right.
Yeah. So for a diabetic lady, the raised NT may be just a result of, it's a suspicion of congenital heart disease. That also we have to keep it in mind. And then we have to evaluate her in the second trimester, 20 weeks onwards for target we do. Right. So second trimester, how would you like to evaluate? You can take up next.
In the second trimester, we'll get her level 2 with all the anomalies tested. And if everything is normal, we'll tell her at 22 weeks, she can get a fetal echo done.
Right.
Evaluate.
Yes. So all the anomalies, in fact, but yes, on priority, you look for congenital heart disease, definitely. And then, of course, all these recommendations are there. So you are, trying to control her on MNT only. But if at all she lands up into anytime she loses her control, maybe you take her. If she is educated, she's ready to follow all your instruction as far as diet, exercise, everything is concerned. And if she's not getting control, so I would in fact ask you, what is the indication for starting insulin for such cases? So Pallavi and Dr. Sonam, I would like to have your opinion.
If the patient is high risk, if she is obese, if she was known case of PCOS, or
same patient, we are following her, no, my dear. So anytime she, you are to control her on MNT, yes.
Fasting as 120 and the postprandial level of 140, 2-hour postprandial level. If it is more, then we'll start the patient on insulin.
Yes, so anytime the 2 hours postprandial goes above 120, not controlled on MNT, and the patient says that, no, I want the best of the treatment. Okay, ideally, what should I take? Whether I should take metformin or insulin, then your first drug of choice is insulin. That is one. Or maybe at testing, first testing, if you find her sugar levels at 200, you have to start her on insulin, preferably.
As a first.
Yes. Right. And anytime she disturbs her control, you have to take her on insulin. As Dr. Anupama said, that if at all she's not responding to metformin, maybe initially you have started, but now she's not responding and the sugar levels are going high, then you have to take her on insulin. Right. So failure of oral antidiabetics. Now we go to, I'm taking short cases with one message for every case. So first one was for screening, second one, whether to start oral antidiabetic or insulin. Now we go ahead with the evaluation we have already done. So you have this primary with 20 weeks, parents are diabetic, she comes to you with the following reports. Fasting 95, postprandial 175. So definitely GDM screening is not done, but her postprandial goes 175. So Dr. Vibha, I think we don't have Dr. Vibha, right? So we go, yeah. So we go ahead with Dr. Sonam, and then Achal. Am I missing somebody? Any of our panelists? Raj Lakshmi. Yes.
I can take that.
Please go ahead.
Case because the fasting blood glucose in this case is 95 and postprandial is 175. So the levels are quite high. So we need to start in this case oral antidiabetic agents. So we will be starting with metformin in this case along with lifestyle modifications.
Yeah. Before that, would you like to do some investigation for her, taking the documentation that is already diabetic?
Yes, ma'am, because we can go for an HbA1c because we are not sure whether
because
75 gram. Yes,
ma'am. So you will not post her for obesity.
No, ma'am.
That will worsen the situation. She's already, you know that she's not able to withstand whatever. If at all, she's already having postprandial glucose high. So why you want to post her additional stress? Okay, yes, so go for HbA1c. If that is high, then how do you decide? Suppose, how do you correlate the HbA1c levels with the rate of malformation? Suppose your patient now immediately you do her HbA1c, it comes to 10. Then how do you inform her about this pregnancy? What is the prognosis?
Ma'am, if it is
more than 10, it's a poor prognosis.
Yes, ma'am.
We should immediately tell her to terminate the pregnancy because there are more chances.
May I know who is talking? May I know who is talking? Is it Pallavi? Who is that? For termination? Pallavi? Manpreet. Okay, so my dear, that is in fact a message we want to give. You are right in a way that you are concerned for the patient. Okay, you are concerned for the patient that yes, the chance for congenital malformation is high, but you are not sure that whether she really has the congenital malformation. So your treatment or your plan of management only should be counseling and not forcing her or advising her for termination of pregnancy. You have to only inform that because your HbA1c is very high, you have a very high risk for having congenitally malformed baby, and we have to go for every test from time to time. And anytime you find that there are some malformations which are major malformations, maybe we have to go for termination. But at this point of time, you will not advise her for termination. Okay, let her take the decision. Once you explain the risk, and if she is not okay, she will say, okay, I want to terminate this pregnancy. Maybe next time you evaluate her, treat her, and pre-pregnancy you control her and make her euglycemic. Okay. So what is this is the recommendation about metformin, that anytime this lifestyle modification alone fails to control glucose, metformin or glyburide or insulin, all these are safe and effective treatment for GDM. But as we have already said that because our Indian women, the literacy level and the understanding is poor, that maybe they don't have access to adequate, the health institutions where actually they can get the guidance or follow-up testing also. That's a reason Government of India has come up with this guideline. Maternal Health, Ministry of Health and Family Welfare, Government of India has come up with this guideline that metformin or insulin therapy is the accepted medical management for pregnant women with GDM, which is not controlled with MNT alone. And insulin is the first drug of choice, though metformin can be considered after 20 weeks of gestation for medical management. Okay. So after 20 weeks, definitely it is safe. Okay, so we don't talk about glyburide because we don't know. And all these guidelines say that metformin is equally safe and effective alternative to insulin. Okay, so we agree, all of us agree to it. This is what we have already discussed, that when should you start the insulin. Okay, now you have taken your patient, you have controlled well. Her fasting is less than 90, her postprandial is less than 120. Suppose you have anytime your patient gets uncontrolled and you have to start insulin. So how do you do that? Should we discuss that or should we go ahead with the next case?
No, definitely.
Okay, because this
we have to discuss.
Yes, so this is a patient where you have to directly start insulin. So let us discuss this case. Okay, you have primary gravida, 33-year-old, 7 years infertility. She is obese, PCOS. Okay, she's conceived on treatment and she continued her metformin. Okay, she is a case of PCOS on metformin. She continued her metformin. She's at first visit when they performed the GDM screening, she was screened positive, but she was controlled on MNT. That is what the history says. HbA1c 6.9 at 33 weeks. Anytime something has gone wrong, okay, macrosomia on ultrasound. So where things have gone wrong and how do we manage this patient now, Dr. Pallavi?
Ma'am, there are several risk factors in this patient. She is obese. She is 33-year-old. She was there's history of PCOS.
Yeah.
And she was diagnosed only on the first visit itself. That must be because she was chronically insulin resistant, and maybe her diabetes got unmasked. So the first line of treatment should have been insulin already, along with medical therapy and physical exercise.
Can you tell me the reason, one more reason? Because she was already on metformin.
Yes, in spite of metformin, she is not controlled. Her HbA1c is only suboptimal.
Yes.
So,
and there is your message very well taken. At first visit itself, she should have been started on insulin. And do you think the history is correct that she was well controlled on? She was
there wouldn't have been macrosomia, and the HbA1c is also suggestive that chronically her sugar was deranged.
Right. So she was not well controlled. Okay.
Self-monitoring
says they must have just done the random sugar sometime here and there, and they felt that, oh, okay, less than 120. I think maybe sometime in between also. So it may not be 2 hours postprandial proper, and that's a very reason many things have gone wrong at many steps. Okay. Now she has macrosomia. Now how do you manage this pregnancy ahead?
Ma'am, after starting insulin, it is important that we do biophysical profile for this patient, serial growth monitoring.
We talk about insulin only first. We have not started her on insulin. How do you start insulin? How many units? And how do you monitor her? How many times you want to do the blood sugar levels when you start initially? Okay, because your patient is pregnant, 33 weeks. You have to see that she doesn't go into hypoglycemia at any point of time.
Yes. Okay. So ma'am, we will do her fasting postprandial levels after 1 hour and 2 hours, and we will assess that what is her requirement of insulin.
So, 1 hour, why you want to do 1 hour postprandial?
Even if we don't do 1 hour fasting and 2 hour postprandial, we'll do where we target 95 and 120.
Okay.
According to that, every 2 days we will repeat her fasting and postprandial and adjust her dose. So we will.
But then first day, how much insulin you will start? We still haven't found the answer.
Ma'am, we will.
I'm just testing you because this is your patient, my dear. You are starting her. So how much insulin?
Ma'am, if it is if it is more than 120 but less than 160, then we start with 4 units.
Perfect. That is what I wanted from you. Okay. So you start with 4 units. If it is so, then how many times? Ideally, how many times you are supposed to do?
2 days. Every 2 days we will check her levels. What we want to avoid is late night hypoglycemia, like postprandial hypoglycemia.
Ma'am, 7-point testing should be ideally done.
Ideally, theoretically, I would say ideally is always theoretically, not practically. Okay,
Yes, ma'am.
ideally
Yes.
7-point testing, as you have already said, 3 meals, pre-meal and post-meal. As you have very rightly said, late night, 2 a.m. Okay, you want to avoid hypoglycemia. So ideally 7-point testing, but practically 4-point testing.
4-point testing.
You say maybe 1 fasting before breakfast and 3 meals postprandial. Okay, because you want to check after the insulin dosage postprandial levels. So 4-point testing initially for first 3 days, you have to make sure that your patient is controlled well, but she's not developing hypoglycemia, right? So for first 3 days, definitely multiple time testing, and you keep a record of this. And then once your patient is stabilized, you go for alternate day testing or every third day testing. Correct. Now, when you do after 3 days, how much should be your level for sugar levels?
The same thing. We target fasting 95 and postprandial 120.
Perfect. That is sure. That is sure. So suppose your patient gets a postprandial sugar levels more than 120. Then how do you
increase the pre-breakfast insulin? We increase that insulin. We increase it by 2 units.
Yeah. Okay. Perfect. Suppose your patient gets a high sugar levels fasting.
Then we increase pre-dinner insulin levels.
Yeah. Then how many times you are giving insulin, that you clarify?
Ma'am, we prefer to give in divided doses. Pre-breakfast and pre-dinner level. Pre-dinner. And since
but then if you are giving 4 units, how will you divide it? If you are giving only 4 units, it will be once, okay, breakfast. But then when your patient is not getting controlled or she's having fasting hyperglycemia, you add 2 units. That is where you add 2 units at dinner. Okay. Okay. And then you got it right. Fasting, when it increases, you add 2 units at dinner. And when the postprandial increases, you add 2 units at the breakfast. So if it was 4, then you make it 6. Okay. Yes. Likewise, slowly, gradually, and that is why the insulin definitely takes time to to monitor your patient. But once stabilized, you can definitely monitor well. Suppose your patient is well controlled now on this, then you want to go ahead. Every third day you keep on testing. If she's on insulin, yes, every third day. Okay. And now how do you deliver? Think of the delivery. Okay. That also we will discuss in the next case now. Here we have 36-year-old, previous one cesarean section, 26 weeks pregnancy. She's diagnosed diabetic, okay? Already diabetic during 3rd month. She's on insulin. HbA1c 6.5. In spite of insulin during 3rd month, her HbA1c is 6.5. Is it a good control? No.
No.
Is it a good control? No. Our blood pressure is 150/90. Clinically, of course, small for gestational age. How do you manage it, Dr. Ishna?
Ma'am, so right now, because she's at 26 weeks, so we have already, I'm assuming that we've already done her level 2 anomaly or NT scans earlier. Now, at this stage, if we have not done her systemic tests like liver function, renal function, because she's also gestational hypertension. So, liver function, renal function, as well as retinopathy should be looked for. That is, fundus examination should be done. She's small for gestational age, ma'am. So, her sugars, like we said, routinely monitored. 4-point testing would be ideal in this patient. And because she is going towards preeclampsia, urine proteinuria should be checked for. And routine, and for fetal monitoring, her growth scans, biophysical profile, and Dopplers. Early Dopplers should be Doppler monitoring should be started in such a patient to see if there is any uteroplacental insufficiency because she has developed early on SGA.
Yeah. So this
And timely delivery.
that is why I have projected here that in spite of being regular registered, she was diagnosed in the third month itself. So as it is, even when nowadays we are doing everything routinely, right? So biophysical and biochemical markers should have been done at 11 to 13 weeks itself. That is where you tried these women, correct?
Yes,
so
yes,
that was not done. And sequentially also quadruple marker or NIPT, nowadays we are doing it for almost every patient, right? Which is cell-free DNA. So all these things were missed, and that is why she has landed up into this complication. So she is now 26 weeks only with gestational, as you said, maybe preeclampsia and also FGR. Okay. So maternal and fetal monitoring we have discussed, but then definitely for this patient, what I have talked to you about, that now here you have to monitor and manage diabetes on one hand and hypertension on the other hand.
Yes,
Right?
ma'am.
And
Yes.
FGR, you have to just take this patient with very carefully to 34 weeks. And if at all you find that everything is fine, well controlled, blood pressure is also not very severe, diabetes is also well controlled, and now for FGR the Dopplers are favorable, then only you can go ahead beyond 34 weeks, right?
Yes, ma'am. Yes,
So
ma'am.
then if you decide to go for the cesarean section at 34 weeks, you
So
have
antenatal steroids need to
yes.
be given with
So
monitoring of sugars, ma'am.
yes. So keep the fetus ready. Now, give magnesium sulfate for neuroprotection
Yes,
at around 32 weeks, maybe steroids also at the same time. Keep the fetus ready. If you can go ahead beyond 34 weeks, well and good, maybe 35, 36 weeks. But if you cannot, maybe you have to deliver the baby at this point and hand over to the neonatologist. Okay. So I think this is the last case. Now, very short case, we take this. Known case of GDM managed on insulin because the levels were high. She came up to suppose 36 weeks. Everything is well under your control, Dr. Sonam. When will you deliver this patient?
If the patient is well under control and the sugar levels are normal, we can proceed the patient up to 40 weeks of gestation and proceed like normal pregnancy, considering the monitoring of blood sugar levels during the
Okay,
delivery.
okay.
And
Yeah, I will interrupt you here also. Would you like to go ahead up to 30, 40 weeks, or would you like to
Ma'am,
induce
ma'am,
at
actually,
39 weeks?
in diabetic mellitus patients and GDM patients, as soon as we achieve lung maturity, we would like to deliver the patient because the sudden chances of sudden IUD and
That is
unexplained IUD are very common in these
That is
patients, and
what
also the fetal weight will increase. So we will have more chances of shoulder dystocia and perinatal injuries during the delivery.
See, nowadays the concept is to induce at 39 weeks, even otherwise normal, healthy, pregnant woman, people are suggesting, and there are so many guidelines. At least for diabetic women, we should not cross beyond 39 weeks. So 38 weeks complete, I think, should be good enough for lung maturity. And definitely, we should try to induce her if at all she is favorable, cervix is favorable, and pelvis is good. We try and deliver vaginally, or maybe then obstetric indication, you can go ahead for cesarean section. But definitely a no beyond 39 weeks. Okay. Yes.
Ma'am, just a doubt.
Yes.
If this patient would have been like a GDM well controlled on diet and exercise, even then till 40 weeks, because earlier we used to like if the patient was well controlled just on medical nutrition
Yes.
therapy.
Just on medical nutrition therapy with no bad obstetric history, yes, definitely. 39 to 40 weeks, you can take a choice. That is what I mean. That is no strict guidelines. For a patient who is on insulin,
Right.
near the term, the insulin requirement goes down, and maybe there is transient episodes of hypoglycemia, which are not, you can't catch them on the record. But this is evidence says that don't go beyond 39 weeks in a diabetic patient. Don't go beyond 39 weeks even in a otherwise non-diabetic patient also. That is what the recommendations are coming up, because there are certain unexplained stillborns, okay, beyond 39 weeks. So inevitable stillbirths, they call it as. So that is why today you heard the talk on FGR and the monitoring also. So there also it says if at all it's a late onset FGR, late onset FGR is where the baby weight is almost 2.5 and near to normal, but the FGR starts later, the flattening starts later, and to this hypoxia, this fetus is not adapted. That is what it is. Okay. The one who is FGR right from the beginning, that fetus is well adapted to this situation. But the one who was, enjoying all the facilities and suddenly now is compromised, that fetus doesn't get adapted well. So that is why the fetus is, you must have heard PK sir saying that late unexpressed stillbirth. You say, अरे अभी यार अभी तक तो सब अच्छा था, बेबी का वेट भी 2.5 किलो है, पता नहीं क्यों हुआ ऐसा. So that is what is late FGR, and that is because the fetus is not adapted to this situation. Same applies here. That is one. And secondly, the intermittent hypoglycemic episodes, which are not, recorded on monitoring. So that is also one explanation for this. So 39 weeks is a very good time to deliver by whatever modality you want to. Okay, so that is what is the, now this is actually a FIGO algorithm. If you ask me, even I don't agree to some of the points here. See, if you have a baby weight of more than 4 kg, definitely elective seizure. Everybody will agree. But to this 4 kg, I'm sure you will agree to me now. But if it is 3.5 plus, you will say, no, we are not going to wait. We go for seizure. So for Indian scenario, I think 3.7 is the cutoff. But more than 3.5 kg, definitely we think of elective seizure. 3.8 to 4 kg, which is a large for gestational age baby. But if everything is well controlled and pelvis is good, everything is favorable, you try and induce her at 38 to 39 weeks. See the FIGO recommendation. Okay, 39 to 30, 38 to 39.
Yes.
But if baby weight is also around 3.8 kg or less, appropriate for gestational age, but poor control, poor compliance, previous history of syllabus, maybe vascular complications. So definitely no to continue up to 40 weeks. That is what is the message. Okay. So I think all of us agree to this. And then, of course, I think I don't go into all this now. It's getting too late, I'm sure. So only one or two messages for labor. If the patient is going into labor, you monitor her blood sugar levels, give her routine diet, whatever she is taking, and routine insulin. But every 1 hourly, you have to monitor the blood sugar levels, and at no point of time it should go below 105 mg/%. And just keep on hydrating her properly, because dehydration is a major risk for diabetic ketoacidosis. That is what does the measure. This is the insulin levels, insulin, how to titrate, that I have given you as per the sugar levels. If at all you are going for cesarean section, elective surgery, then you have to skip that day's insulin and go for cesarean section, deliver the baby, and then you titrate, do the blood sugar levels, and then you see whether she needs dextrosaline or whether she needs insulin as per the levels we have already given. Go for, ask her to continue with the MNT, whatever she has, continued throughout pregnancy, because she is the one who is going to land up into the type 2 diabetes mellitus over next 5 to 10 years. The incidence is said to be 20 to 50%. So that is why continue this healthy lifestyle. Okay, diet and exercise, weight reduction, and then contraception, of course, copper T is the ideal contraception, not non-hormonal. Okay, you have to do her blood sugar levels after 24 hours, after 1 week, and after 6 weeks. And then, of course, once in a month, if at all the sugar levels are high, you have to continue breastfeeding. That itself, consumes 500 calories of the mother, and that helps you in reducing the, weight of the woman also. So that is how we have to adhere to the protocols of testing and advocacy. Hyperglycemia in pregnancy, what we have already talked about, that it is universal testing, that is every pregnant woman during every pregnancy. So we have to diagnose at the earliest. We have to give her 2 weeks time if she is positive, give her a medical nutrition therapy, and then if she doesn't respond to that, then only go for medication. 90% of these women respond to medical nutrition therapy, only 10% require some form of medication. So if the patient is well enough, educated, understanding, compliant, then go for insulin. If at all she is not educated, staying at a distant place, go for metformin beyond 20 weeks, definitely. So that is why we have already talked about when to deliver and how to deliver. So with this, I conclude this panel. I would be very happy to have a few words from the expert, but before that, I would just thank all of you and just take this humble opportunity humbly to request all of you to please support my candidature, vote for me in large number, as I'm contesting for Foxy Vice President from West Zone. All of you know me since so many years, and I have had huge number of votes last time, 10,657. Just by little margin, I have I could not make it. So this time I request all of you, please, please vote for me and help me reaching there as your own representative. Thank you so much. Dr. Anupama, I would be very happy to have some expert comments from you also.
Thank you so much, Sneha ma'am. It was a very, very enlightening session. Not only this last panel, but the show was yours, and all of us know that it was just because of your hard work. And all of us, don't worry, at Uttarakhand Society, we are there to support you, ma'am. And you don't really have to worry. I'm sure a president like you in future, right now, the right step is vice president.
Yes.
And I just hope that with time, when if it is possible as a vice president or later on as a president, these guidelines I still feel that need continuous upgradation.
Yes,
And metformin,
definitely.
as they say that right now in your last message, you had said that metformin is to be stopped and not to be given between 12 weeks till 12 weeks to 20 weeks, right? That is the time when it is said that it is usually not to be given. But I feel that many updates are coming which says that it can be given. So it is a continuous process and it will evolve with time. Yeah.
Yeah.
So
I would just once again you add whatever I have said. You are right that the guidelines said that you can start the metformin only after 20 weeks, right? In fact, practically when we discussed that, we said no, beyond 12 weeks we can start. But you will also agree to me that the PCOS, what you are using, obese PCOS infertile patient, you are continuing her on metformin. If she becomes pregnant or if she conceives, you continue her, right? But then there are lots of studies where there are no malformations detected. Patients are, continuing, as you rightly said. So definitely the guidelines need to be revised
upgraded
over and over again. I have already made a statement in some other program also that, guidelines are done by a small group of people who are, and you have a huge chunk of clinicians practicing over 30, 40, 50 years. So they are never considered. Okay. So I think you understand the message. So that is why all common Foxians need to come together. It is our organization.
Exactly. And that is why we want a hardworking representative like Dr. Sneha. and we really wish to see you at the helm, ma'am. Don't worry, from the Uttarakhand side. And Shweta was also there, and I would want all of us to, the presidents and secretaries will have to vote for the committee. She was contesting for the modern
Actually,
technology.
Dr. Anupama, I request to say that, because I'm for Foxy vice president, every member has to vote for me. So it's not only president, secretary.
Yes. I forgot to mention that it is not only the presidents and secretaries who have to vote for vice president. पिछले साल तक मैम vice कुछ कह रहे थे मैम?
Everyone has to vote
and president, every member, every Foxy member, whether junior, senior, absolutely no. Every Foxy member who is eligible for voting can vote for me. So I request all of you.
मैडम के 1000 वोट तो पक्के होने ही चाहिए इस बार.
Don't worry, Sneha, you are going to get many votes from.
मैम सर्वेश्वरी मैम ने आपके सर पे हाथ रख दिया, अब कुछ कहने की बात ही नहीं है. थैंक यू सो मच. एंड मैं अभी मैसेज पे डाल रही थी कि हमारे पैनलिस्ट वर सो गुड. आई वाज पल्लवी, एशना, मनप्रीत, सोनम, एवरीवन, सब लोग इतने अच्छे से बोल रहे थे. आई वाज सो ग्लैड. मतलब फिदा हो जा रही थी तुम लोगों के ऊपर.
Thank you so much, ma'am.
As an expert, I was keeping quiet because they were speaking such nice way.
बहुत अच्छा, बहुत अच्छा. This is the way the panel.
And Dr. Surbi, I can see Dr. Surbi is still there. Can
Yeah, Dr. Sneha, one point I would like to add that Foxy has recommended vitamin D testing also because are vitamin D deficient or more medium. This I read today only.
Yeah, definitely. Thank you so much. Thank you so much once again, everybody. Thanks, Dr. Manu and Dr. Arti Ludra, and thank you, Radhika, as well, for all the hard work. And of course, thank you, all of you, all the presidents, secretaries, and of course, the president of Uttarakhand for the collaboration. And thank you so much for the lovely program. It's always
Thank you.
nice to be with you. Thank you, dear. Thank you so
Thank you
much.
for having us, ma'am.
Bye.
Thank
Radhika is
All the
not here,
best.
but on
All the
behalf of
best.
Radhika, I would want to thank first of all Radhika and then
Yes.
Sneha ma'am.
Yes, that is what I'm saying. The so much of
All,
she said, Sneha, madam, you just don't worry about this program. You continue because I had alternate day programs.
I
She
understand.
said, Sneha, madam, you just don't look at this. I will manage everything. And I'm so happy.
मैम
she
हमारे
did.
यहाँ पे भी ना
But
3-4 वेबिनार अभी बैक टू बैक होते रहे हैं और वो
हाँ,
सारे राधिका नहीं मेंशन किए. मैं बीच में आउट ऑफ कंट्री थी, अभी कल ही रात को वापस आई हूँ. सो कल आते ही आते पहला फोन मुझे आपका आया स्नेहा मैम. मतलब व्हेन आई लैंडेड एट माय प्लेस आप कह रहे थे ना नंबर फोन नहीं मिल रहा, तो दैट वाज द
नहीं मिल रहा.
रीजन.
Correct, correct. So
Yeah.
thank you so much, dear. Thank you so much.
so don't worry. Everything will be all right. Okay?
Yes,
Ma'am, definitely.
thank
Thank
you.
you very much. It was a wonderful session.
Yes, Radhika. Thank you so much.
राधिका मैम चली गई है, वो एक्चुअली मेरे पास मैसेज आया था उसका
ठीक है,
कुछ
Okay,
अर्जेंट
okay.
काम.
It's
Thank you so
okay.
much.
It's
Thank you.
okay.
Bye-bye. Bye.
Thank you. Bye.
बाय.
you for
थैंक
having
यू
us,
एवरीवन.
ma'am. Bye.
Bye-bye.
Thank you, dear. Thank you so much. Bye.